could use some right now.
So now David's here.
Yeah, but when he goes on stage though, I guess I'll know him.
Okay. Yeah, and then I'll sit here so that I can actually see.
Yeah, because you get him from up
Yeah,
there.
because if I'm on this side, I can't see. How much you're smiling today because your day is over.
Yeah.
That's what we all know. And
Yeah.
by tomorrow, we'll be feeling the same. Yes. Okay. Thank you.
Oh, that's Noel. Okay. She's from Panama. So she speaks Spanish.
Okay, we're David. It disappeared on me.
Yeah.
I'm just kind of waiting. But there's David. Now I can start. I like how she said, Shannon said. Okay, David, I'm going to go ahead and start up. And we'll go ahead and do yours that have presenters since we
Okay.
don't know the
Dr. Gibson's here too, so let's see, we've got, we've got
Mike's are on,
breakthrough
baby.
pain. Thanks.
Okay, so which one's for you?
This one,
Breakthrough pain. Okay.
We could.
GABA. Disorders of GABA. Disorder of metabolism. GABA, that one, Dr. Gibson is here too.
Okay.
This one, of course,
we want to
Dr.
do
Manica is
chemistry?
here. Oh, yeah, sorry, I'd mentioned that earlier. So, yeah, breakthrough pain, Catasil,
Okay.
GABA. Of course, Dr. Maniker's been here for a while too. He was one of the first people I saw.
Okay.
Um,
So we'll do
let's see.
yours, and then
Non-ruptured cerebral aneurysm, Dr. Paul Rao. I've not seen him yet.
okay. Good morning. You're looking very
You're
tired.
here.
Okay, long story. I got
Okay.
it. Never mind. Okay. Yeah. After I do the introductions, I'm just going to come back down here. But I'll
That sounds good. Sure.
Okay.
Okay. Wow.
When you go up
Let me
there,
just-
I'll do your slides.
Okay.
Okay.
Okay, good morning, everyone. We're going to go ahead and get started. Welcome to the second day of the ICD-10 Coordination and Maintenance Committee. We will be covering the diagnosis topics today. For those of you who weren't here yesterday or listening in, we were actually able to cover several diagnosis topics yesterday afternoon. So instead of 39 topics in one day, we're down to about 29 topics in one day. Still a large amount, so we're going to try to move along as expeditiously as we can, but leave lots of time for discussions of the various topics being discussed today. Also, as a reminder, or for those who weren't with us yesterday, the proposals that are being considered for today's discussions are being considered for October 1, 2018, except where noted. There were several proposals yesterday that were being requested to be considered for October 1, 2017, and I believe there are at least 2 topics today. For those proposals that are being considered for October 1, 2017, we need to have your comments into us no later than April 7, so that we can take a look at those and see if the proposals actually are supported and whether or not more work is needed, and whether or not we can actually accomplish including those proposals into the October 1, 2017 update. Again, in your handout, you have the timeline, so that includes the dates for proposal, new submission of proposals in keeping for consideration for the September 2017 meeting. And we encourage comments on proposals that are not being considered for October 1, 2017. We still encourage your comments to come into us by the end of June, so that way we can take a look at those comments and see if any of the proposals perhaps need additional tweaking and need to be represented at the September 2017 meeting. For those of us who were here yesterday, you'll notice that there were several topics that have come back multiple times. So, and that's not unusual. I see laughing and nodding of heads, okay. Yes, several of them came back. I think we might have broken a couple of records, but some of them that actually came back 3 times. So we, again, would like to have your comments in sooner than later. Just to break from the remarks, for today's dial-in, the meeting ID number has changed, and I will read that off to you. 904377806. And 904377806. Thank you, Maddie. Information about CEUs is in your material, so I won't go over that. The addenda for October 1, 2017, we expect as CMS to post those in June to give the industry time to do the updates to be ready for the effective date of October 1, 2017. As noted yesterday during the CMS remarks, we will be posting updates to the general equivalence maps. However, this will be the last update of the GEMS, and we will be reverting to what we were doing in the days of 9CM with the updates of the conversion table. And conversion tables were posted this year, both for ICD-10 PCS and ICD-10 CM. With that, I would now like to start moving us into the discussions of some of the proposals, and I will be inviting Dr. David Berglund, our medical officer, to lead the discussions on the next several set of presentations. Dr. Berglund.
All right, and we'll be covering a few presentations. For those following along in topic packets, our first presentation this morning will be on breakthrough pain. Those following along in their handouts, it'll be on page 18, and we'll have some slides. We have slides, and we have here today Dr. Jeffrey Gooden. He is the Director of Pain and Palliative Care at Inglewood Hospital and Medical Center. He's board certified in pain management, anesthesia, addiction medicine, and hospice and palliative medicine. So quite a number of board certifications, I'll say. Very active in teaching and research and lectures widely on topics in pain management, palliative care, and addiction medicine. Dr. Gooden, I'll turn it over to you.
Thank you. Appreciate it. Good morning. Thank you. And it's a pleasure to be here to present to the committee on this very important topic in pain management called breakthrough pain. Pointer only. Let's see if I have the slide controls. As mentioned, I'm a pain and palliative care physician. I work out of one of the Mount Sinai affiliate hospitals, or former Mount Sinai affiliate hospitals. We've just announced a relationship with the new medical school in New Jersey called Seton Hall Medical School, so we'll be changing affiliations. I run the hospital's pain and palliative care division, so you can imagine I see patients with all kinds of pain: acute pain, chronic pain, postoperative pain, and cancer and terminal illness like pain. And what I'd like to do today is bring you up to speed on where we stand with a concept in pain called breakthrough pain, which is something that doctors very commonly talk about, but currently there's no specific diagnosis code for. Okay, so to put us all on the same page, sometimes we categorize pain in different fashions. We've all heard the terms acute pain versus chronic pain. Acute pain is something that happens instantly. It's expected to go away in a short amount of time. That's the body's natural response to healing. Chronic pain, on the other hand, is usually defined in our literature as by any pain that doesn't go away when it's supposed to. If you're really looking for a date, they say 3 to 6 months or longer. If you still have that pain, we can call it chronic pain. There are different patterns of pain. Some patients will have intermittent pain with periods of no pain in between, and other patients have persistent pain. I'm going to talk to you about those differentiators in just a moment. Sometimes we categorize pain by how severe it is: mild, moderate, severe, or even crisis pain, which we see often. From a scientific standpoint, we can categorize pain based on its location or the type of tissue where it comes from. So I tell the medical residents all the time when they call me for a pain consult, what kind of pain is it? And they usually say, well, it's bad pain. I'm like, well, that's not the answer I'm looking for. Where in the body is it coming from? Is it from the musculoskeletal tissues? We call that nociceptive pain. Is it from the organs? We call that visceral pain. Is it from the nerves? We call that neuropathic pain. There are some differentiators where we call it cancer pain versus non-cancer pain. And I've always kind of had trouble with that distinction, because if you have a compression fracture, a vertebral compression fracture, and it's from osteoporosis, it's probably just as painful as a vertebral compression fracture from a malignancy, from cancer. But yet we distinguish pain between cancer and non-cancer pain. So another distinction that we're going to talk about this morning is baseline pain versus breakthrough pain, and I'll explain more about that in just a moment. Breakthrough pain is a term that's been around for a long time in the pain industry that clinicians usually use to describe a flare of pain. But it's a very specific flare. It's a flare that occurs in patients who are otherwise controlled on their medications. So if you're not on any pain medicines and you have a flare of pain, we call it a flare. But if you're on an around-the-clock regimen of pain medicines and your pain breaks through that regimen, we call it breakthrough pain. Now, it's been reported in the pain literature since the 1980s. Again, it occurs on this background of stable, persistent pain in patients who are already getting pain medicines. It's differentiated from acute pain, like the way I just described, and also from chronic pain that's not managed. If the chronic pain isn't managed, we adjust their around-the-clock medicines. But even in patients who are optimized on around-the-clock medicines, still have these spikes or these flares of pain, and that's what we're talking about here when we call it breakthrough pain. Now, the original work came out in the cancer pain literature out of Sloan Kettering and some of the New York hospitals, but certainly the literature reflects that plenty of patients with non-cancer pain also get these episodes of breakthrough pain. Now, I'll point you to the screen, and hopefully my pointer works here. Everything that you see in the yellow rectangle here might represent a patient's all-day-long or around-the-clock pain. And then these intermittent spikes that you see here of variable intensity can represent their breakthrough pain. So again, the bottom kind of stable baseline is where their regular pain is, and then during the day, they can have flares of pain, either mild flares or severe flares. And when you look at the characteristics of these flares, some patients will say, you know, doc, every time I blank. Sit in the car, stand too long, move my bowels, have a coughing spell. I get one of these episodes of pain. And then other patients will say, these episodes of pain can just come on like that, in minutes, out of the blue, without any specific instigating factor. When you look at the literature, it says the median time of onset to reach peak intensity is 10 minutes, but in up to 40% of the patients, it's 3 minutes or less till the time that they're in severe pain. It usually lasts a short amount of time. The literature says it resolves on its own in about 60 minutes. So let me be clear. If patients don't do anything for that episode, it goes away in about an hour's time. That's one of the characteristics of breakthrough pain. So you can imagine that if we have a pain, especially in cancer patients, that comes on in minutes and goes away in about 60 minutes, using the typical pain medicines that you think about, like the Percocet or oxycodone-like medicines, those medicines take 60 minutes to reach their peak effect. What benefit does that have in a patient who has their peak effect of pain in 3 minutes? There's a disconnect to the timing of the way patients get pain. These episodes can happen any number of times throughout the day. The literature says somewhere between 1 and 4 times. And when you look at the prevalence, it was 59% in a 2014 review. As you can imagine, if you're one of these unfortunate patients who suffers with breakthrough pain, you're going to visit the doctor more, you're going to go to the ER more, you're going to cost the healthcare system more, and it's probably going to be associated with a lower quality of life. You can't sleep, you can't function, etc. Clearly, in the pain world, we know that survival is linked to analgesia. Isn't that amazing? In the palliative care world especially, we're recognizing that. The more comfortable patients are, the longer that they live. So we know that it's related to outcomes. So breakthrough pain is a burden on the healthcare system. Now, I want to differentiate again the two kinds of pain when I see a patient that I try to elicit from my interview. Tell me about your all-day long pain, and tell me about your intermittent breakthrough episodes or your intermittent flares of pain. Because these two types of pain are treated differently. And you can't treat it effectively if you don't assess for it. So I ask patients, tell me about your baseline of all day long persistent pain. And most patients will say, doc, I'm probably a 6 or a 7 out of 10 on most of the day. But then I have a few times a day where I hit a 10. And most patients don't say 10, they say 20. I say, no, it only goes to 10. They say, no, it's a 20. They try to tell you just how bad their breakthrough pain is. And as I mentioned, giving them the traditional short-acting opioids like morphine or oxycodone or hydrocodone, those take 60 to 90 minutes to reach their peak. It doesn't make sense to treat breakthrough pain with a medicine that takes too long to work. So here's what I learned. I trained in New Haven at a fairly prestigious academic center, and I learned that if you want to capture all of these spikes of pain, take their pain patch or their extended release opioid and raise the dose. Just keep raising their extended released analgesic. You know what? Eventually we can control the patient's pain, but here's what the family says. Mom seems to be doing better from a pain standpoint, but she falls asleep in her cereal, she falls asleep in her soup, she falls asleep in her spaghetti, she hasn't moved her bowels in a few weeks, she gets the excessive side effects, over medication of opioids. Come into the hospital, and what do we give you? A patient-controlled analgesic device, a PCA, where you push the button and you get an instant dose of intravenous medicine so you can control your own analgesic coverage because those medicines work quickly. Well, we have a class of medicines now, and there's 5 or 6 different agents in this class. They're mostly fentanyl products delivered through the mouth, believe it or not, that work rapidly, that can almost mimic this pattern of treatment, where patients can get rapid relief from their breakthrough pain. Now, as you can imagine, a rapid onset opioid is associated with certain risks, and obviously we need to counsel patients about those risks, but doctors are prescribing these agents each and every day. So, if you were to do chart reviews like I do for many of the insurance carriers, you see breakthrough pain as a common statement in clinician medical records, although there's no code for it. So we code right now on the basis of acute and chronic pain. You might also see in the chart a flare or a flare-up or an exacerbation of pain or a transient increase in pain. So in order to get this special rapid onset medicine, the patient needs to have a diagnosis of breakthrough pain. That's required because these medications are part of an FDA program called a REMS. It's a restricted program called a Risk Evaluation Mitigation Strategy Program. So on the one hand, we have to have patients enroll in the REMS, we have to document they have breakthrough pain, yet we don't have a code for breakthrough pain. Having a unique ICD-10 code for breakthrough pain will help us identify and differentiate breakthrough pain from the other kinds of pain that I told you about, their acute pain or their around-the-clock persistent pain. It'll allow us to do some data analysis based on nationwide data. Most of the data that comes out on breakthrough pain now is done by patient surveys, not the most efficient way to collect data. And clearly, if we had a code, we could help develop clinical recommendations supported by some of this claims data analysis. All right, so obviously each and every day we read in the paper about the current public health crisis of the opioid epidemic. Some portion of those opioids comes from clinician offices. We can't help that. Remember the television commercials? The medicines come from the medicine cabinet. We need to teach patients how to store and control these medicines better. But the more and more we read, we see that the majority of the medicines are coming from illicit sources. Non-pharmaceutical fentanyl sources are probably the most common source of the deaths that we see from heroin and fentanyl on the streets. So in order to enable more robust data analysis, having a unique code for breakthrough pain to differentiate it from the other kinds of pain will allow us to better identify patients to give them a justified use for the opioids. So if a clinician gives a patient that diagnosis, the specific ICD for breakthrough pain, we'll understand what kind of pain it is and that more than likely their use of medications is justified. It'll help facilitate access to the medication. Again, the medicines specifically for breakthrough pain through the FDA REMS say that the patient has to have a diagnosis of breakthrough pain. But right now we don't have a code for breakthrough pain. And clearly it'll help draw attention to provision of opioids only when they're genuinely needed, because you'll know that a clinician has clearly thought about the diagnosis and coded specifically for breakthrough pain. I appreciate you letting me use my New York pace. I promised 10 minutes or less, and we can open the floor for questions.
All right. So any clinical questions for Dr. Gooden now?
Does it make a difference if it's neuropathologic breakthrough pain or visceral breakthrough pain, or is it just all breakthrough pain is the same, or is there a difference?
No, there's a difference physiologically in the type of pain. Now, to the patient, it might be similar from a suffering standpoint. From a science side, there's definitely a difference. If you're asking me from a coding side, just thinking out loud, I'm not sure there's a difference that we need to categorize a difference for the origin of that breakthrough pain.
I mean, now's the time to ask if you want it.
So let's think out loud together. Should we sub-specify whether? Yeah. Okay. All right. I'll avoid the details. Okay. Please.
Jeff Linzer, American Academy of Pediatrics. I have a couple of questions dealing with your proposal. First of all, how would you make sure that this code wouldn't be misused, for example, in a patient with hemoglobin SS disease and vaso-occlusive crisis?
Yeah. So if that patient with hemoglobin SS disease and vaso-occlusive crisis was on long-term around-the-clock opioids and was relatively well controlled and had breakthrough flares of pain, it might actually be appropriate. That's breakthrough pain. Now, obviously, we need to determine if they're in crisis, that's a medical emergency. We treat that as a medical diagnosis. But having been in the pain practice for 20 years or more, I'll tell you, we have some sicklers in the practice who we've kept out of the hospital by providing them more liberal analgesics, clearly under monitored guidance. Urine drug screens, pharmacy monitoring, prescription drug monitoring database. So it might be an appropriate code for those sicklers when they're not in crisis. If they're in crisis, I think that's a different medical diagnosis.
You see, I'd be concerned how that code could be misused. The other thing that concerns me is your definition. You're implying that a patient has to be on opiate medication constantly as opposed to other types of analgesics such as long-acting NSAIDs.
Yeah, it's a great point. And this is one that's been debated at, there's been some consensus meetings as to what should the actual definition of breakthrough pain be. And one of the definitions you could find in the literature is exactly what you're alluding to. A patient who's maintained on non-opioid analgesics, but for the purposes of our discussion, and especially for this sensitive class of medicines, the most important thing is safety. And to use this particular class of fentanyl medicines, the basic tenet above all else is the patient has to be opioid tolerant. That means they need to be on at least a certain number of milligrams of opioids every day for at least a week or longer. So it would not include the patients who were just on daily NSAIDs.
You see, that concerns me because I can see the physician writing breakthrough pain with the patient is on nonsteroidals, for example, and is getting a bolus of an opiate drug at that time. The coder's not going to know the difference, whether the patient's been on chronic opiates or chronic NSAIDs or some other class of analgesics. So your data is going to be skewed.
Well, we're hoping that because of the REMS program, this particular REMS is not an optional REMS. This is a mandatory REMS for the products that we're talking about. That means that clinicians have to register, pharmacists have to register, patients have to register. They have to sign a patient prescriber agreement that says this drug is, or this class of drugs is only for use in opioid tolerant patients. And it gives all of the definitions of what opioid tolerant are. So from a definition standpoint, I'm almost in your camp. I think breakthrough pain can be in patients who aren't necessarily maintained on opioids. But as a separate issue, if you want to have access to that fentanyl class of breakthrough pain medicines, you need to follow the restricted guidelines which say you have breakthrough pain, you have a cancer diagnosis, and you have opioid tolerance based on the definitions.
Well, that may be fine for your research study, but in the real world, when a physician is going to write breakthrough pain, it's going to be coded. And it'll be coded as breakthrough pain.
Yeah. So but I'm kind of missing the point. I'm okay with them coding breakthrough pain if that's what it is. I don't think we need to define, or I don't think the panel needs to define from a coding standpoint whether the patient's on baseline opioids. I don't see that going into the definition. I can see the definition being pain that breaks through their daily regimen of analgesics.
So why couldn't you use acute on chronic? Why wouldn't that be sufficient?
Because again, it comes to the point that in order to get access to a specific class of medicines for breakthrough pain, the FDA says you need a diagnosis of breakthrough pain. That's just part of the REMS.
Okay, but once you're outside of that, I just try to see how this would apply outside of your research study, and how the coders are going to understand to use this as the physicians document it.
I mean, I'll give you an example. So we have a 7 or 8 person oncology group at our hospital. If they see a patient who has chronic pain related to malignancy, there's a ICD code for that. If they see a patient who has chronic pain related to their malignancy that's been stable, but they have breakthrough pain, it would give them the opportunity to code breakthrough pain and then code chronic pain secondary to malignancy, so that if the patient needed this class of medicines, of which there's 5 or 6 in the class, there would be data to show that the patient indeed has breakthrough pain, that the clinician has determined that they meet the criteria for the diagnosis of breakthrough pain.
For your study, but...
No, not for a study. This is every day, in everyday practice. We're not talking about a research study.
And one last question. On your first slide, you indicated you had disclosures, but they didn't show up on the screen. Could you give us your disclosures, please?
Of course. So I am a consultant to industry. I could submit my disclosures. I could tell you there's probably 10 or 15 different companies on the list with analgesics in development and analgesics on the market. Being a key opinion leader, I probably have consulted for a dozen or so different entities to bring new products, novel products to the market, but also done consulting and promotional work for most of the companies that have analgesic products. Other questions?
All right. Let's move to the coding part of this presentation. And if we could, let us get the screen to show exactly that. See, he knew exactly what I wanted. Thank you so much. All right. You can sit down. You can sit here in case there's more questions. There always could be. So I appreciate it. Thank you, Dr. Gooden, for your presentation and for the clinical information you've shared. And let's look now. And if there were questions as to where this came from, I will repeat it. It does have in your handout also there on page 18. That the specific ICD-10 CM code request for breakthrough pain was requested by Insys Therapeutics Incorporated, that is a pharmaceutical company. We can't say they're a disinterested bystander or something, but on the other hand, we recognize that this can be a complicated area. Thank you, Dr. Linzer, for your comments and thoughts on this also. Looking now at the proposed tabular modifications that we have in this, it's proposed that at G89.1, acute pain not elsewhere classified, that a new code be created, G89.13, titled breakthrough pain. And as Dr. Linzer was observing and questioning, and Dr. Gooden was confirming somewhat, while I think part of the impetus behind this was the idea of breakthrough pain, particularly in opioid-tolerant patients, we would not have anything as far as a definition of breakthrough pain here. We would basically be presuming that physicians would be using the term breakthrough pain, and the coders will be seeing that term on the chart and then using this code. That would be the thought behind this, of course. And that could be in any of a few contexts. It might be in a acute hospital setting or in a palliative care setting, or a hospice setting. So we're not specifying the context other than that, too. Looking at other things, we would have a use additional code note, use additional code to identify the underlying chronic pain and its etiology, and such as things, chronic pain due to trauma, chronic post-thoracotomy pain, neoplasm-related pain, and other chronic post-procedural pain would be things. This is a such as note also, so it would not be limited to those by any stretch. And then we would have a couple of other code first notes at G89.2, a chronic pain not elsewhere classified. We would add a code first note, code first breakthrough pain if applicable. And the same at G89.3 for neoplasm-related pain, again, a code first breakthrough pain if applicable. So that's the proposed changes. Comments?
Jean Yoder, you might want to consider a use additional code for the long-term drug use, the Z79, and then that way you could tell if it was the steroids or the opioids or whatever it was. So there's just a possibility that you could put that there to help the coders understand that there's got to be some kind of long-term drug use before they can have breakthrough pain. Because I didn't know you needed long-term.
Well.
People I hang around with don't use it that way.
Okay. And certainly there's issues. So, okay, a potential use additional code for long-term drug use, that could be something, or if applicable, as it were, might be something to consider. Okay. Any other comments? Okay.
Hi, I'm Linda Holtzman from Clarity Coding. I'll give you my disclosures right up front, Dr. Linzer. I was involved in developing this proposal. Gene, that's a really good thought about a Z code for you're welcome. Well, it was for the long-term drug use. That's really good. I just wanted to comment that I don't see an issue with physicians diagnosing breakthrough pain and documenting breakthrough pain in a non-opioid situation. You could code that too. Why not? you know? But I think what Dr. Gooden is saying is that there are certain situations, particularly the opioid, where access to certain therapies is not available unless it's known that the patient has breakthrough pain. So this would identify it in those situations. But certainly it has uses in other situations as well.
Okay. Thank you, Linda. Any other comments here?
Nellie Leon, Chisane American Hospital Association. Linda's right. We wouldn't, as a coder, we would not be looking for clinical criteria for this condition. So if the doctor documents that it's breakthrough pain, that's where we're going to code. So Dr. Linster, if you think that physicians are documenting breakthrough pain in other situations with a different definition, I'm not sure how widely accepted is the definition that we just heard today. It sounds like depending on the setting or the patient population, the terminology may be used differently. But coders would not be looking at is the patient receiving long-term opiates or any of these things, because that's just not what we normally do.
Right. So I think this wouldn't, at this point, in potentially creating or proposing to create this, we wouldn't necessarily be expecting it would just be limited to the situation Dr. Gooden mentioned. On the other hand, for their purposes, of course, in the research and the things that they're doing, they would have other criteria for applying in determining who would be getting the particular class of drugs they're referring to. So I would say then this code could be applied both for them and for some other cases that might be more broad. But for their purposes, at least, it would, I would imagine, help to narrow things down a little, if nothing else. So I don't think it's necessarily a problem that it might be applied more widely also. But I would certainly invite comment on that from everyone. And we're interested in hearing input on how this might be used in practice and on how useful it might be. Or if there's concerns or ways we can improve it, then we're interested in hearing that too. Okay, any other comments at this time? Dr. Gooden, anything else you wanted to say?
Thank you for the committee's time.
Okay, thank you for being here, and we'll...
Open the line for questions.
Sorry, what?
Open the line for questions.
Oh, do we have the line open? Do we have the line able to be open for questions on the phone today or not? I was not sure if that was possible. Maddie, do you know if the phone lines, can the phone lines be open for questions?
All lines are now unmuted.
Hi, this is Dr. Erica Reamer. I have a comment.
Yes.
Yeah, so as a clinician, I was an emergency physician, and I used to use the term breakthrough pain whenever it seemed appropriate, which was when a patient was on chronic pain management and they were having an acute flare. My one question is, are there any other, like I used the term breakthrough pain, but are there any other synonyms that clinicians in other localities might have the practice of using that we want to make sure get indexed to breakthrough pain?
Any comments on potential synonyms?
Yeah. So not sure this is the direct answer, but as I mentioned during my presentation, you might see clinicians use the term transient exacerbations, flares, acute episodes. So obviously part of this initiative would be educating clinicians as to what breakthrough pain is and getting them to use the terminology when appropriate.
Okay, thanks. Any further questions?
This is Dr. James Kennedy. I am a physician. I believe that this classification of breakthrough pain should not be under G89.1. I think that this is in the context of G89.2, which is a chronic pain and should be a 6-digit. Right now, that's one of the beauties of ICD-10 is the addition of the 6th and 7th digit. I believe that this should be part of, in context as to which of these chronic pains under G89.2, G89.3, or G89.4 had the breakthrough. I also believe that there should be a 7th digit for the level of pain, much like the physician described level 4, 4 out of 10, 6 out of 10. This gives us a way of using the coding system of measuring the severity of pain according to a standardized scale, and then being able to model our treatments and costs in association with that. Thank you.
Okay, thank you, Dr. Kennedy. And I will comment, we did look at that as an option when we were considering this at first. And that would be something that could be possible to do. Our thinking on this was that it would be possible to expand and add additional characters for the acute type of pain that a breakthrough pain is that's on top of chronic pain, and then to basically specify it that way. There would need to be potentially quite a number of additional codes added that way, and it could be at least somewhat less clear. Essentially, then you would have chronic pain with breakthrough pain. And the clinical characteristics of breakthrough pain, basically that it is on top of the other pain, it seemed reasonable to us to have a single pain that could be used together with the other existing chronic pain codes. One of the clinical characteristics of the breakthrough pain is that it appears it's an acute pain that's on top of a chronic pain. So we felt classifying it at the G89.1 was appropriate. But we are certainly open to hearing comments on that and on how this might work in practice in the classification. Again, that would be a potential option, especially if you were going to add 6th and 7th characters. You could very quickly end up with a huge number of additional codes created rather than using a single new code together with the other existing codes. And as we attempt to apply ICD-10 CM codes in ways that are consistent, it seemed more appropriate to us to be able to just use more than one code for that. But I would very much welcome input from the public on that question. Did you have any thoughts on that, Dr. Gooden? That's primarily a coding-related question, I suppose, so I don't know if you want to weigh in on that or not, but thank you, Dr. Kennedy, and we appreciate your thoughts on that. Again, it was something we contemplated before we moved to this particular option that we are proposing at this time. So any other comments?
It's Linda Holtzman again. I just wanted to add on to Dr. Berglund's comments in response to Dr. Kennedy's comments, that this particular structure that we came to after working it through, we felt that in addition to not creating an explosion of new codes, this also preserved the structure, the existing structure of the pain codes, which are popular codes. They're used very frequently. People are accustomed to them. So we felt that by just adding one new code and then using codes in combination, that would both identify breakthrough pain and the circumstances under which it was occurring with the additional codes, and leave the existing code structure intact. So we felt this was maybe a better way to go, but open to other ideas.
Okay. Any other comments here or any other comments on the phone lines at this time? All right, hearing none, I think we're ready to move on. Thank you, Dr. Gooden. All right. And looking at where we will go next, next we have a presentation, Catasil, and we have here today Dr. Sate, who is, she is on the advisory board with the Cure Catasil Association, and she has followed a number of families with CADASIL, and she's also the director of Pompe Clinical Development at Amicus Therapeutics, which is unrelated to CADASIL, but is what she's currently doing. Dr. Sate, let's have you come up, and we have your slides up here now too, so go ahead and come on up, and we'll talk about this. We'll have a discussion of CADASIL next. Thank you, Dr. Sate.
So, thank you so much for this opportunity, and it is really exciting for me to be here. The slide advancement is...
That was the pointer, and this, you have to use forward.
Okay, thank you. So these are my disclosures. I am currently employed full-time with Amicus Therapeutics, but I would like to say that we have no product, no compound, nothing in the preclinical or clinical development with Amicus. We deal with Pompe disease and Fabry disease, so there's no conflict of interest with respect to CADASIL presentation. I'm an associate professor at Rutgers, and I do maintain a practice. I'm a member of the Cure CADASIL Association Advisory Board, and I'm sorry for the misrepresentation here. It should have said Cure CADASIL Association. And I'm really making this talk on their behalf. They had petitioned the ICD-10 code, and I'm a neurologist to several families with CADASIL over the past decade. So CADASIL has the longest name in medicine, actually. It does have that credit. It's cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Though the name is very long and complicated, CADASIL, I think, serves the purpose, but at the same time, the name really says it all. It's a cerebral disease. It predominantly affects the brain. It does not affect other systems as much. It's autosomal dominant by inheritance, by Mendelian inheritance. It's an arteriopathy, so it affects blood vessels, especially the small and medium-sized blood vessels. And what it actually causes, because of that it causes infarcts, which are small strokes, and leukoencephalopathy, meaning white matter disease in the brain. So that exactly what the disease is, and the name appropriately describes the whole situation. So why should we have a new diagnostic code for CADASIL? Well, primarily because it is an independent condition. It has a gene described. It is not caused by, as far as we know, by any other gene abnormality, but abnormality in Notch3. It is similar to any other genetic disorder, such as Huntington's disease, a number of them, or cystic fibrosis for that example, or Tay-Sachs, or any other disease where there's a specific genetic deficiency identified and has a specific disease related to that gene abnormality without any interference or any confounding factors. It is inherited, so present at birth. It's a lifelong disease and a very multifaceted kind of disease. It really changes its presentation every decade. So unless it has a specific code, it will be very difficult to capture the entire description of the patient without a code. And I'm going to go over a little bit of that in this presentation. Now, because we don't have an ICD-10, there is no way to identify the prevalence of the disease in general population, and there is no way for the patients to get recognition for the whole gamut of presentations that they have, or the whole difficulty that they possess because of this abnormality. And just to give an example, for example, if it's a Huntington disease and there's a code, right away it triggers a number of advantages for the patient, I would say, in terms of, say, rehabilitation or in terms of long-term care, whereas not having a code for CADASIL really is a big disadvantage for the patients. So just briefly to go over the condition itself, as I said, it's a Notch3 mutation. It doesn't matter what chromosome it's coded on, but it's on chromosome 19. It's a very long gene, and there are very unique aspects about the molecular biology of CADASIL. There are about more than 200 mutations now described. There is a homogeneity among mutations that they affect a particular amino acid. And the Notch protein itself has a different role in prenatal and postnatal development. But in the postnatal development after birth, it is involved in maintaining the caliber of the small blood vessels. I don't know if I put, yes. So it is involved in maintaining patency of small and medium blood vessels throughout the body. It's not specific to the brain. However, if you have CADASIL, it doesn't mean that 100% of the blood vessels drop off. And therefore, in the other organs of the body, though there is a drop off of blood vessels and the blood vessels simply collapse, the circulation is maintained because there is a lot of crosstalk. Just example in the lung or kidney or skin anywhere else. So originally CADASIL was diagnosed based on a skin biopsy because you can see the characteristic appearance of blood vessels on a skin biopsy. In the brain, however, by a very bad design by nature, the deep parts of the brain that I have circled here are supplied by end-on vessels, as we see here. They really have no crosstalk. And so there is not much of provision to compensate for blood vessels that are dropped off by this process in CADASIL. So small blood vessels cannot maintain their patency, they begin to collapse, and so deep parts of the brain will no longer receive blood supply. And this is cumulative over the lifetime of the patient. So in the beginning, there is some compensation, but as the patient gets older, the compensation is lost and they'll start manifesting more and more symptoms of CADASIL. The outer part of the brain has blood supply, dual blood supply. It also receives blood supply from these vessels, but it also has blood supply from external blood vessels. So it is kind of protected from the effects of CADASIL. However, the deep parts of the brain, the white matter and the deep gray matter, have no chance because eventually they'll be very ischemic and they'll have scarring and death of the tissue because of lack of blood supply. So brain is really a bystander in this whole phenomena. The other organs are spared because of the crosstalk. So in terms of how common it is, it's very difficult to know at this moment how prevalent CADASIL is. Right now, the expected prevalence is about 2 to 4 per 100,000. The recent estimate came in as close as 1 in 25,000, which is 4 in 100,000. And this was based on a study done in England where they studied the pattern of notch mutation in a specific population and then estimated that prevalence. So this is about 2/3 to half of prevalence of Huntington. So it's not that off from a similar or a parallel disease that causes neurological deterioration. And now just to capture CADASIL without a code, this is how difficult it is. Okay, so the white matter abnormality in the brain may be occurring as early as the teens. We don't know that because we do not necessarily image people at this point when they don't have symptoms. But they start off with migraine with aura by the age of 15 or 20, and this migraine gets more and more complicated as time goes by. The aura may be very complicated, and in the mid-30s, they start having episodes of stroke. Now, there is a bit of an overlap, and as they get more and more episodes of stroke, for some reason, migraine seems to abate. The mood disturbances in this picture is really shown by 40s, but I've certainly seen patients with mood disturbances much, much, much earlier in the course of their disease. Eventually, because of so much of affection of the brain, they start presenting with features of dementia, apathy, and eventually the patient with CADASIL will get demented by the age of, say, 60, late 50s to 60s. And in between, these ischemic strokes leave behind a lot of motor disability, so they'll have difficulty moving one arm or one leg, difficulty walking, swallowing, all of the disability left behind by stroke. Now, without a code, these patients get coded as different things at each point in their time without any continuation of their symptoms saying that it is the same disorder that caused this until this. And some patients, it doesn't mean every patient has every one of these, but at some point they'll at least have more than 2 or 3 of these features. And unless there is a specific code, it is very difficult to recognize the whole spectrum of symptoms that the patient may undergo throughout their lifetime. And again, this is how the white matter disease progresses, and therefore the amount of disability or the amount of symptoms that these patients accrue over time. It starts off with periventricular white matter, and by the time they reach their 50s, almost entirely the periventricular white matter has white matter lesions, whereas the deep gray matter in their 40s or before is much less, and by the time they go to their 50s or 60s, the periventricular white matter, which is the dotted line, the last bar, I'm having some difficulty with, this here, is the last one to accrue white matter lesions. So by the time the patient is in their 50s, almost every part of the brain has white matter lesions and has suffered some effect of loss of blood supply. So this is a progressive MRI in a patient from CADASIL. This is not from the same patient, different patients, but just representative in each decade, starting from the left upper corner, the patient in the 20s. And just for orientation, this is a cut taken in a in a transaxial manner, meaning going from the nose to the back of the head. And the big chunk of white in the middle, which is symmetric on both sides, that's normal. That's the water content of the brain. But apart from that, I wish this pointer stayed. I'm just going to keep it. Apart from that, whatever appears white in this gray area of the brain should really not be white, especially in the 20s. We don't expect anything white, and you can already see these small white dots beginning to accrue. In the 30s, there are certainly more now. In the 40s, they are becoming confluent, and more areas involved, and by the time the patient reaches their 60s, almost entire white matter, which should really appear gray, is now whited out. And so...
Has another pointer that may work better, sorry.
I don't know if, do you want to go back to the previous slide? But this, all of this white that appears white on this particular MRI here should really not be white. It should really appear gray like this. It appears in this 20-year-old person. And here we are seeing these small edges of white matter accrual, which increase here, and then here becoming confluent, progressing in their 50s to really bigger patches, and then entirely. And so it's a very prolonged course of illness. The patient may present to the physician at different points of time. Suppose the patient doesn't have a severe migraine, they may or may not see a neurologist. Their primary physician may manage the condition, and at that point it may be missed. But then that's going to be coded as a different thing. When they start getting strokes, they present with their white matter disease, and they present with a transient neurological deficit. A number of them get diagnosed as MS. And there is a whole literature on how these patients are misdiagnosed on MS for a period of time, and they get treated with medications for MS for mostly because of misdiagnosis, but also because of lack of awareness that there is another disorder which is very similar and can present in a manner almost identical to MS. It has very huge implications for the family. It is an autosomal dominant disorder. So every child born to a person who carries the CADASIL gene has a 50% risk of actually inheriting the gene. So, it is not likely that this population will shrink over time, but in fact, the number of patients identified with CADASIL will certainly increase over time, and as we become more aware of the disease and there's more genetic testing, we'll have more and more patients getting diagnosed with this condition. And in late stages then, if the patient really didn't get diagnosed at this time, eventually they'll become demented, and it will be identified as vascular dementia, meaning dementia caused by lack of blood supply, but will get coded then as just routine vascular dementia and not necessarily CADASIL. So, I think a specific ICD-10 diagnostic code, it has a specific gene, it has a specific phenotype, it has a pretty large number of patients who are affected by this condition, and it will really help us identify the prevalence, further the research, provide appropriate services to the family, because having a diagnosis, suppose the patient is not that demented but has severe migraine, without a diagnostic code, you're not able to actually pick the whole picture and provide the services, the long-term care that these patients really need in this condition. And I always say that this is almost similar to Huntington disease. It is autosomal dominant. It causes progressive neurological deterioration and eventually makes the patient dependent on others for their activities of daily living and other needs. So I think this was, I just included this.
First, are there any clinical questions for Dr. Sathe? And this time I could ask, could you open the phone lines for any potential clinical questions on the phone lines?
All lines are unmuted.
Okay, not hearing any clinical questions at this time. We'll move on to the ICD coding changes. And maybe you can stay on hand just in case. There might be some questions later. And could we switch the display to the other computer at this time? Okay. So, and I will say we did look at a few options here for this. We were looking initially at the potential to include this in the neurological chapter, but based on our review and looking also at how World Health Organization was handling this in ICD-11, For those following along, we're on pages 21 to 22 in the topic packet. Now we're on page 22 here. So we're proposing to put this at I-67, other cerebrovascular diseases, and I-67.8 is other specified cerebrovascular diseases. We're creating, it's proposed now to create a new subcategory, I-67.85, and title that Hereditary Cerebrovascular Diseases. It's proposed to there create a new code, I-67.850, for CADASIL, spelling it out as cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, with CADASIL being an inclusion term. We would also propose a code also note for any associated diagnoses such as stroke, epilepsy, and vascular dementia. And at the same time, we would also propose to create a new code I-67.858 for other hereditary cerebrovascular disease, and that could include other things. While at this point we're not proposing that other specific things go there, that would include, for example, something like, I think, CADASIL, a autosomal recessive diagnosis that otherwise is somewhat similar to CADASIL, as I understand. And without detailing what other things might go there, in any case, this would be consistent with how World Health Organization was handling these disorders in ICD-11, and it would give us potential room to expand in future, and it would put CADASIL with other cerebrovascular diseases, which seems to follow along with the clinical picture that we have and that Dr. Sate has been reviewing with us. So that's the proposed changes. Any comments on this here or on the phone lines?
Yes, I'm Janice Regazzo, and my daughter is a CADASIL sufferer. She was diagnosed at age 24 with her symptoms started with a migraine, and she had a stroke. I just wanted to really stress to the maintenance committee how important it is to the CADASIL community to have this ICD code put in on ICD-10, because as you know that it took the United States 20 years to go from ICD-9 to ICD-10, and I know that we're on the beta draft for ICD-11, but from talking to many researchers and physicians, they said you're probably looking at another 10 and 15 years, especially the coders themselves. We have a woman who worked 35 years as a coding specialist, and she says that just implementing the new ICD-10 took so long for her to go across the country to teach the people to code it. So I'm stressing so strongly in, as a mother, a wife of a CADASIL sufferer, and my other children, that the ICD-10 CADASIL gets put onto that code. Thank you.
Thank you. Any other comments at this time? Okay, well, I will encourage everyone to put comments in writing, and we'll look forward to hearing more from you. Dr. Sate, I appreciate your being here and presenting on this for us, and we'll wrap things up. Now, are the phone lines open, and were there any questions that we missed there? To double check. Anything on the phone lines?
Dr. Kennedy here. Are there any other hereditary cerebral vascular diseases that we may want to add besides CADASIL, since we're looking at this? Does the speaker, can she think of other ones that we must consider, so that way we don't have to revisit this in the future?
Dr. Sate, go ahead. You should be able to speak from there, certainly.
Yes, there are a number of inherited cerebrovascular disorders similar to CADASIL. CADASIL is one of them. It is the same long name except for autosomal dominant, we read also autosomal recessive. Then there is HERNS, which is hereditary endocrinopathy, nephropathy, retinopathy. All of those disorders, though, are recessive and therefore in prevalence much less because of the recessive nature. CADASIL is dominant, and as time goes by, more and more disorders will be described. In my mind, it may be good to have a provision for those disorders. But if they're autosomal recessive, their prevalence may really be much, much less. And if we group them as other inherited cerebrovascular diseases, I think it may be okay. The prevalence for CADASIL is much, much, much higher, being autosomal dominant.
Mm-hmm. Thank you, Dr. Sate. So yes, I'd mentioned CADASIL there when I was discussing the other hereditary cerebrovascular disease. I'm thinking we would potentially want to index other things there. We may not need to list those as inclusion terms, at least at this time, but we're certainly happy to hear input about these and to consider that. So thank you for all the input, and again, please put comments on this in writing, and we'll look to see what directions we can go with this. All right, and I think we're ready to move on next. Actually, at this point, the thing we'll move to next, I think, will be on disorders of metabolism of gamma-aminobutyric acid, GABA. And for those following along in the topic packets, that will be on page 28, and Dr. K. Michael Gibson is going to be speaking for us on that, and he is the chair of the Department of Experimental and Systems Pharmacology at Washington State University. He is the person who discovered the enzyme deficiency in SSADH deficiency, and he's discovered a few other enzyme deficiencies, a couple of other ones, as well as being instrumental in a couple more beyond that. So I'll say, as I told him, my undergraduate degree was in biochemistry, so I'm very impressed. Dr. Gibson, I'll turn the podium over to you.
Thank you. And do I control the slides? Thank you for that nice introduction, Dr. Berglund. Forward.
Control slides of that, and you've got a pointer.
I got a pointer that works. Well, hey, all right. So the request is to add an ICD code, ICD-10 CM code for rare diseases of GABA metabolism. So let me just jump right into it. And so far, this has been very educational. I really enjoy this. It's quite a different process. So as Dr. Berglund alluded to, the request is to specifically have a new code for disorders of GABA metabolism, gamma-aminobutyric acid metabolism, within the existing, quote, other disorders of amino acid metabolism. I think probably the audience will think of amino acid disorders like phenylketonuria, which is one of the more common ones, for example, which has newborn screening. So we want to put a code in there within the context of disorders of amino acid metabolism. So what are the disorders of GABA metabolism? GABA is a non-protein amino acid. What does that mean? So when you think of proteins, you think of the 20 physiological amino acids. You think of leucine or phenylalanine or tyrosine that are built into proteins. Okay, GABA is a neurotransmitter. It is not built into proteins. It's a major brain neurotransmitter. You all well know that glutamate, which is the precursor of GABA, is excitatory. GABA is inhibitory, so it works on a chloride channel. We know of two disorders of GABA metabolism, the so-called succinic semialdehyde dehydrogenase deficiency, SSADHD. That's getting pretty long itself. And a GABA transaminase deficiency. So what are the genetics and the metabolism of these two disorders? SSADH deficiency, which I've worked on for well over 35 years. It's rare. It's an autosomal recessive disease. It's on chromosome 6p22. It's caused by mutations, recessive mutations in the aldehyde dehydrogenase 5A1 gene. Aldehyde dehydrogenase is a large subfamily of aldehyde dehydrogenases. It's a block in the conversion of succinic semialdehyde to succinate. So the GABA backbone basically enters the Krebs cycle. Dr. Berglund loves biochemistry, so I'll give him a little dose of biochemistry there. That's the defect shown there. It results in accumulation of both GABA and an interesting other neuromodulatory compound, gamma-hydroxybutyrate. You may have heard a little bit about gamma-hydroxybutyrate in the past as a so-called sexual assault perpetrator-type drug. GHB is interesting because it has a very short half-life in the body. It's a drug, illicitly used drug with a sort of onset of euphoria, but it also has a short-term amnestic effect. So it's had some interest in the literature over the years as used in acquaintance sexual assault. Looking at GABA-T deficiency, it's the enzyme step right before SSADH deficiency. So it's GABA-T is here. It blocks the conversion of GABA to the semialdehyde. It is ultra rare because it's been so difficult to pick those patients up. Probably only about 10 known patients. It's ultra rare, okay? It's on chromosome 16p13, and it's also a neurometabolic disease, just like SSADH deficiency with mutations in the ABAT gene. That's aminobutyrate aminotransferase. It features accumulation of just GABA, but other analogs of GABA without GHB. The severity of the disease between patients over the 3.5 decades I've worked on SSADH deficiency it's very heterogeneous, okay? It is a non-specific neurological disease, okay? So patients present to a variety of clinics. They miss early motor skills. They may show ataxia. They may show hypotonia. When they get into adolescence, they might show or well show neurological morbidity, neuropsych morbidity, including obsessive compulsive disease, aggression deficit disorder, attention deficit disorder, obsessive compulsive disorders, etc. Variable epilepsy and SSADH deficiency, but it's a very non-specific neurological disease. You cannot diagnose it clinically. The same as you cannot diagnose just clinically GABA-T deficiency. That's more of an epileptic syndrome, which we originally thought in the 80s was basically a lethal disease. But now that both disorders are on next generation sequencing panels, we're finding more and more patients. These are panels specifically set up to diagnose patients from a molecular perspective with epilepsy or autism or so on. So more and more neurologists are using those kinds of panels. Geographic locations of SSADH deficiency, about 200 documented patients, so still extremely rare. All over the world, of course, as a recessive, we see much higher incidence in those countries where there are interrelated marriages. In the Saudi population, in the Turkish population, in the Greek population. We really believe it's significantly underdiagnosed, predominantly because you have to have a specific urine organic acid test, and in the case of GABA-T deficiency, you can't find GABA in plasma. You really can't measure it. The mechanism up until now, before next generation sequencing, to identify GABA-T deficiency was to use cerebral spinal fluid and look at GABA levels, the neurotransmitter. And you can imagine it's very difficult to do lumbar punctures. So what's the need? What is the rationale and the need here for ICD-10 CM coding for these two disorders, these rare disorders of GABA metabolism? The current ICD-10 CM coding doesn't allow for classification and identification of the disorders of GABA metabolism. It doesn't address the diagnostic needs in clinical practices, and it doesn't allow specific targeted insurance coverage. The challenge with these disorders is patients with these disorders end up going through sort of a diagnostic odyssey. Okay, they may show up with a psychologist, a child behavioral psychologist. They may go to their pediatrician. The pediatrician can't get a diagnosis. Eventually, they'll be referred to neurology, and neurology may or may not order organic acid testing, or may not do next generation sequencing, because epilepsy may or may not be present, autism may or may not be present. So I'm representing the association, the SSADH Association, and they're strongly behind this coding change request. They are unique disorders. So in the current headings, there are disorders of beta amino acid metabolism. Okay, you can look those up, and I'll actually show you them. I'm being a little presumptuous in how I presented that, but here goes nothing. They are gamma amino acid disorders. So the organic aciduria in SSADH is a gamma hydroxybutyric aciduria. It's not your typical organic aciduria when you think about things like propionic acidemia or methylmalonic acidemia. It is an atypical organic acid. And the amino acid is very atypical. It's gamma aminobutyric acid. It's not beta-alaninemia. It's not tyrosinemia. It's not hyperphenylalanemia. It's a gamma amino acid. It's very specific. There are unique neurotransmitter features to both of these disorders with GABA as an accumulating compound. Okay, it's inhibitory neurotransmitter. So I guess I'm being a little presumptuous, but we would presume, sorry about that, to have a new diagnostic code 7281, which would include both disorders. They go by multiple names: GABA transaminase deficient, GABA T deficiency, SSADH deficiency, succinic semialdehyde dehydrogenase deficiency. So we would hope that there would be multiple descriptors under that. The proposed reclassification would help both with disease identification, with research and treatment, would help with development of GABA in newborn screening, and would even give more impetus to putting aldehyde dehydrogenase 5A1 onto the newborn, onto the next generation sequencing panels. And I think I'm about out of time. With the addition of NGS panels, predominantly from the neurology clinics, we have seen a significant rise in the cumulative enrollment in the SSADH Association patient numbers because of the increased number of hits for getting those patients through molecular confirmation. So I think I'll skip over that and just give you a quick update. We are actually also working right now in our own laboratory, but with other investigators, to develop a newborn blood spot screening assay for both disorders based on GABA in blood spots, which would be something we hope we could add with treatment development onto the newborn screening panels. So we hope to, with this new ICD code, formalize these two disorders as distinct entities, raise awareness, shorten the diagnostic odysseys, okay, and also improve the possibilities for research as well as, obviously, research reimbursement for these disorders. Questions? Okay. Thank you.
Thank you. Any clinical questions for Dr. Gibson at this time?
Jeff Linzer, American Academy of Pediatrics.
Yes.
It's been a while since I've done my OChem. And aren't there other GABA chromosomal abnormalities as well besides this? I mean, you make these sound like these would be orphans and orphanettes.
When you think of other GABA disorders, there certainly are GABA receptor type disorders. So there are known mutations in the myriad subunits of the GABA A and GABA B receptors. There's only 3 steps in the pathway of GABA metabolism. So there's a synthetic enzyme, glutamic acid decarboxylase. We've never yet, to my knowledge, identified a patient with a disorder in GAD, glutamic acid decarboxylase, which makes GABA. And the only 2 steps in GABA metabolism are those 2 enzymes. That certainly doesn't preclude multiple possibilities of GABA B receptor subunits, there are theta, beta, alpha subunits, allelic abnormalities in those where the GABA ligand would have difficulties binding and opening the chloride channel pore, for example. So in terms of the metabolic sequence itself, those are the only 2 known because of those only 2 steps.
Okay. The Academy did not have an opportunity to preview this proposal ahead of time, so we will submit this to the appropriate section and include that with our comments.
Thank you.
Okay. I was going to just say, one I'd seen when I was looking at things was hyperkeratosis, which is something that's very rare, even more rare than these others. I think it was described in 3 children in one family over 40 years ago, and apparently there haven't been any cases since, so I'm not sure if it's very applicable to, I don't think we necessarily need to index it there, but it might be related to, I don't remember exactly what the biochemistry was in that particular instance. I don't know if you...
Dr. Berglund raises a good point. There has been just a very brief number, perhaps 3 or 4 publications from the 60s and 70s of patients with a disorder called homocarnosinosis or homocarnosinemia. Homocarnosine is the dipeptide form, sorry for the biochemistry, but I know you like it. Yeah. Homocarnosine is the dipeptide carrier of GABA. So homocarnosine, L-histidine joined to GABA makes homocarnosine. It turns out that over the years, over the decades, we found that homocarnosinosis is basically allelic, is synonymous with another defect called carnosinase deficiency, which is a defect in the metabolism of L-histidine with beta-alanine, the beta amino acid, not with GABA, which is homocarnosine.
Okay. And yeah, that. So yeah, in any case, I don't know that one would be particularly applicable. We may want to send that one somewhere else if we actually index it even, but it's probably rare enough it's not as much of an issue. So at this point, we wouldn't necessarily anticipate more things going to this code based on what we know of that. In any case, again, GABA being a neurotransmitter is quite different from most amino acids, most of which are not neurotransmitters. So in that respect, there's a lot of difference from the other things that it's lumped together with at the particular code where it is classified. So while these are relatively rare disorders, it does look like certainly the clinical difference from other things is another impetus for potentially separating it. If we could we have the presentation go to the other computer here, and let's look at the proposed tabular modifications here quickly. So at E72, other disorders of amino acid metabolism, E72.8 is other specified disorders of amino acid metabolism. We would propose to add a new code, E72.81, for disorders of gamma aminobutyric acid metabolism. And again, this would include a number of things. The SSA-DHD is succinic semialdehyde dehydrogenase deficiency, and the GABA-T deficiency is another one. So we would propose or GABA transaminase deficiency, so various terms that have similar meaning. And we would also propose a new code E72.89 for other specified disorders of amino acid metabolism, which would include the disorders of beta amino acid metabolism and disorders of the gamma glutamyl cycle. So those are other things which would go to the E72.89. Certainly there would be more room to expand here in future if that seems necessary or appropriate, so we would have that possibility also. At this point, and I will comment, we did have a suggestion also to create a new code for elevated GHB, the gamma hydroxybutyrate, also called 4-hydroxybutyric acid, and you'll note we've got one thing there. At this point, we're not proposing to do that. That would be essentially more lab-related disorders, things found in the urine. So if someone has GHB elevated in their urine, it's possible they may have SSA-DHD. It's possible that they might be abusing GHB, or it's possible that they might have had someone attempt to assault them by giving them GHB intending to rape them. So there are those possibilities. We don't, as far as organic acids go that are checked in the urine, GHB is one of them, but for purposes of testing for organic acids for hereditary disorders, there are over 60 things that are tested, and we'd be hesitant to try to break out and just look at GHB. And we'd also be a little worried about the way that might get mixed up with potential for trying to check for other things also. So at this point, we've not proposed anything related to that, but that's something else to consider. So any questions or comments either about the proposed codes or clinical questions that we might not have asked for earlier?
I have a clinical question and a coding. The first one, you list all the symptoms of this disorder, have like epilepsy and so on, right? Does the patient always have this, like epilepsy and so on, if having this diagnosis?
Let me let you answer that.
Oh, doggone it, I'll let you answer. Epilepsy is seen in the SSADH deficient patients, SSADHD. Epilepsy is seen in about half of the patients. We still, in terms of GABA T deficiency, we really they're both encephalopathies, obviously, but I think epilepsy is much more prominent in GABA T deficiency, although there's only about 10 patients. And so epilepsy is not a common feature, although one of the more common misdiagnoses of patients with SSADH deficiency is as autism. And that can obviously be overcome with either organic acid analysis or certainly with molecular confirmation.
Okay.
Did that address the question?
Yes,
Good.
because as a coders, I would like to collect this data for you, but we need instruction to how to collect it.
Right.
If the patient has this diagnosis, there are varieties of signs, symptoms, and conditions
Right.
go with it. We need instructions say that co-also or co-additional if the patient have this. So that way you know which patient have what in our data.
Mm-hmm.
That's what I'm suggesting with coding.
Good. Thank you.
Hi, Laurie Johnson from Panacea Healthcare Solutions. My question may be a little bit clinical as well as coding, but it seems that family history may be an important part of this disease. And my coding question is that perhaps we need to develop a family history code as well so we can make that connection. We do have a family history code for Huntington's chorea. So, just thinking that's another congenital or family, I should say, genetic disorder. So that may be something we want to consider to add as well.
Well, that's an interesting point. I guess I would posit that something like Huntington's chorea prevalence or incidence, or
Right.
whichever genetic term you like to use, is significantly higher. So what we're talking about, probably based on our estimate of current alleles, is approximately 1 in a million right now. That puts the frequency of carrier heterozygotes out there at very small numbers. So while I think it's an admirable approach, I don't know that it would necessarily, in terms of family history, be very beneficial for SSADHD or certainly GABA T. What happens generally is that we have a family history once the first proband is diagnosed. And then, obviously we can move from there because
Right.
by recessive we have obligate carrier parents.
Right.
So,
I was thinking in connection with the newborn screening,
Right.
and then if there was family history, that both of those could be. And I understand it's an ultra rare condition, so, but just a thought.
it's an interesting thought too about, you gave me something to think about in terms of the potential utilization of blood spots for carrier testing, which is very dangerous, and I'm not even going to get near the HIPAA or the IRB or the FERPA questions involved with that. Please.
If you write a paper on it, though, partial credit.
Okay.
Yeah? Laurie Johnson, right?
Okay.
Panacea.
Thank you.
My question is actually more on the coding side, Dr. Berglund. Okay. And I don't mean to put you on the spot, but I've been thinking quite a bit about coding for rare and ultra-rare disorders. And I don't even know that there's an answer that you need to give. I just want to raise the point. In the last few years, we've had a number of requests, and I've been involved in some of them, for distinct codes for rare disorders. And sometimes we get a code and sometimes we don't. You know, that's the way it goes. And these are obviously ultra rare, 10, 200, not even in the US, but worldwide. I don't object to creating a code. I think it's a good idea. But I guess where I'm going with this, and I am going somewhere with this, is that does NCHS have some criteria or philosophy perhaps on creating codes for rare disorders? Because you mentioned that even though these are rare, the clinical distinctions and the possibility for additional identification of additional disorders that would fit in this category might be a good reason to go ahead and create it. Now, I agree, but I'm just wondering if there are other criteria or philosophical points.
That's an excellent question. I will say I don't like to put any specific numbers out there, trying to throw numbers around or what have you, and there can be legitimate reasons why one might consider codes in some circumstances where either, particularly if, for example, we were moving something somewhere other than where the World Health Organization was classifying it, or if there's other particular clinical groupings and evaluation that can be useful for one reason or another. For things like this, again, at this point, we're not proposing a unique code for a single disorder. Mm-hmm. This is
I see you were
being
breaking
couched
out
as
gamma.
a disorder of GABA metabolism, which includes more than one disorder. Mm-hmm. Although primarily it would be two that we're more aware of that are both relatively rare. But
ultra rare was the term you used.
Yeah, it is in any case looking at GABA metabolism, that being a neurotransmitter that's somewhat different from the proteins that we usually think of when we think of amino acids. Or at least those of us who are biochemists think of these things when we think about amino acids, and other people's eyes might glaze over, but that's, we deal with that.
I had to take the Krebs cycle 4 times in college, and finally, 30 years later, it came in handy.
Well, I'm glad to hear it.
No, and I'm not asking you necessarily to have a specific response. I just wanted to raise the philosophical issue.
Sure. And we do think about that some. I will comment that when you look at rare disorders, when you look at the information about it, we actually include things as rare if there's less than 200,000 cases. In other words, there's relative degrees of rarity, and if something has more than 100,000 cases, then that's a lot, I would say. If there's more than a few thousand cases, then it's probably worth considering at least creating an ICD code for in more definite sense. That would be like things with a 1 in 100,000 usually. That's something that we've usually tried to look at. When it's less than that, then we're probably more likely to question and wonder about it. So this one with SSADHD and things, it's in the area where we may want to certainly take it under consideration and get input, certainly. But again, I think there are reasons, and I think the way this is being approached, particularly with, as I'd said, with it being a neurotransmitter as opposed to a regular amino acid used in protein metabolism, it's got differences that are of clinical interest, certainly. I think one can make a case for it. I think Dr. Gibson made a wonderful job making a case for it, and we're looking for input from the public on this, and we will see what the comments are. Dr. Maneker, did you want to comment, or are you no, walking toward the mic? But I tell you, and let me see. Could we open the phone lines for comments and questions? I don't believe I'd asked for those yet.
All lines are now unmuted.
Okay. Okay. Any comments from the phone lines? I guess not. All right. That being the case, I think we've covered this in detail. One of the suggestions coding-wise was the idea essentially of creating something like maybe a code also or use additional code note for things such as epilepsy and autism. That could certainly be something we could consider. Certainly not having a note would not imply that that it would not be appropriate, although that might not be clear to coders when it is something that's related to a known underlying disorder. So it could be useful to have a code also note that would enable coding things such as epilepsy or autism. And I'm not sure we would want to specify ordering, given that there could be different reasons why someone was admitted, and coding something like epilepsy first might be appropriate in some clinical circumstances, as an example. So we'll consider that, and we welcome input from the public on that question. If there's no other questions now, I'll say thank you, Dr. Gibson, and we appreciate your being here and presenting for us. And looking at where to move next, I am going to turn the podium over to Donna Pickett at this time, and she will tell us where we're going next.
Okay, if you'll go to page 31 in your topic package, the next topic we will be discussing is the electronic nicotine delivery system. I'm not going to read through all of the material here. You have it in your handout. But obviously this is an important topic. I know AHA has received questions through the editorial advisory board related to e-cigarettes. And of course, we're seeing a lot of things in the various literatures. So again, I'm not going to read through the entire background materials, and we'll just move directly to the coding proposals. So on page 32, for the coding proposal, basically what the American Thoracic Society is requesting are parallel codes for ENDS, or e-cigarettes, to mirror the codes that already exist for cigarettes, chewing tobacco, and cigars. And so what you see here are the proposed new codes within the F17 nicotine-dependent section of the classification, and also parallel codes in the T65 section for the toxic effect of the e-cigarettes. And then lastly, an expansion of the Z72.0 tobacco use codes to split out, which is currently now just a Z72 with no further refinements, to actually create expanded codes for tobacco use, which would include your chewing tobaccos and your cigarettes and cigars, and then a new code at Z72.02 for the electronic nicotine delivery systems, which would include e-cigarettes and all of the other terminology that is currently used to describe the use of these devices. And Dr. Maneker, if you would join us, I think that would be good, and then we can open the line for questions and also to the audience. Dr. Maneker.
Thank you. Thank you, Ms. Pickett. Thank you, Dr. Berglund. It's really an honor and a privilege to be here. We appreciate the opportunity to speak this morning in support of our request for these new ICD-10 codes. I want to assure you I'm going to try and speak in less than 5 minutes, given the immense agenda before you today. I am representing the 15,000 members of the American Thoracic Society, both adult and pediatric pulmonologists, both physicians and advanced practitioners dedicated to the diagnosis, treatment, and importantly, the prevention of respiratory diseases. Today, we're not going to be talking just about pulmonary physicians, but also the many specialists of our organization, including critical care, sleep, radiologists, thoracic surgeons, allergists, allergists, anesthesiologists, and other physicians, all of whom are lined up in support of this proposal. And as well, I'm speaking on behalf of a coalition of societies and groups, including CHEST, or the American College of Chest Physicians, the Campaign for Tobacco-Free Kids, the American Lung Association, and the American Association of Pediatrics. And I know Dr. Lindsay will have some comments when our comments are ended in support here. So the code structure is as described by Ms. Pickett. It's very easy to understand. It's intuitive for use by clinicians and scientists alike. The new electronic delivery devices are inserted in a very natural position adjacent to the appropriate codes for the use of cigarettes and or chewing tobacco. The language is extremely clear. It's easily identified with electronic health records and the numerous synonyms that can be used in searches and with prompts for clinicians. Importantly, it allows for the coding of the use of these electronic devices in addition to the use of codes for cigarettes and chewing tobacco, and even non-nicotine containing compounds within the devices, which do have harmful effects. Critically, this complementary coding is going to be important for individual persons using multiple devices, because just recently, as 6 weeks ago in the New England Journal of Medicine, a very large prevalence study here in the United States demonstrating that 40%, that's 40%, of current tobacco users here in the United States employ multiple product types, and the most common type is in fact cigarettes and electronic nicotine delivery devices. The most important question that I need to cover in the remaining 3 minutes or so of my 5 minutes is why we are requesting early implementation of these codes. We would like for these to be implemented October 1st, 2017, this year, not October 1st, 2017, 18 months into the future. And why is that? Our children. Virtually all of us are parents, aunts and uncles. Some of us are grandparents. Some of us are godparents. Some of us are teachers or public health officials, and we all love our children. 8% of electronic device users are never smokers. It's the largest growing group in individuals using these devices. In middle schoolers, in 2011, 0.6% of kids were using these devices. 4 years later, in 2015, it was 5.3%. That's an almost 9-fold increase. Among high school students, it went up in 2011 from 1.5% to 16% in 2015. Over 10, almost 11-fold increase. It's enormous. There are many compounds, aside from nicotine, that can be put in these devices, and either these compounds themselves or the heated byproducts are harmful to our children. They can produce diacetyl or formaldehyde, which produce varying forms of lung diseases. A byproduct called acrolein is a known human carcinogen. And there's mounting evidence here in the United States that the use of these electronic nicotine delivery devices are a gateway to tobacco use and conventional smoking, particularly in children and in teenagers. These new codes allow harnessing the power of the increasingly prevalent electronic health records in use in our practices and our hospitals. They allow early identification by nurses, by advanced practitioners, as well as physicians. They allow earlier tracking of outcomes and the adverse health effects later in life. And there is no need for supercomputers to process big data. There's no need for genetic sequencing to achieve personalized medicine. We can achieve personalized medicine for our children, for our teenagers, and even for adults of all ages by incorporating these new codes sooner rather than later. And early interventions are possible, again, leveraging the power of our electronic health records with decision support tools to identify children, teens, and adults who could benefit from potential interventions. 1 year in the life of a 9-year-old 6th grader that you love is a very long time. Please, don't wait for 7th grade. Don't delay, and implement these codes in October 1 of 2017. Thank you.
Thank you, Dr. Maneker. What we'll do now is we'll open up for questions, both clinical and coding. And I see people going to the microphone. I also, before we start with the comments and questions, wanted to indicate that on the bottom of page 31, and I know this comes up frequently about who's supporting the proposal, we have support for the creation of the new codes from the American Association for Respiratory Care, the American Lung Association, the American College of Preventive Medicine, and the Campaign for Tobacco-Free Kids. And with that, I will recognize Dr. Linzer from the American Academy of Pediatrics. Dr. Linzer.
The Academy's had the opportunity to review this, and we support the measure, and we would support early adoption.
Thank you, Dr. Linzer.
Hi, Jean Yoder. I understand the request for early adoption. I'm not sure if that's the best long-term, because the codes are supposed to be used when they impact the episode of care. And it may be a sign or symptom of when a young person is using electronic nicotine delivery system, but I don't know how frequently that impacts the episode of care, and therefore I don't know if and as was mentioned, sometimes I believe that it's not necessarily nicotine that is in the delivery system. And so it may be that we need to relook and think about, does this electronic nicotine delivery system, where maybe we need to change the header to tobacco use and electronic nicotine, because, or electronic delivery systems, or vaping, or whatever they call this stuff nowadays. But it's just that perhaps putting this here, because it says tobacco use, and it may not be tobacco, and we may need to change the title of well, it's not a category, it's a subcategory. I got it. I learned that a long time ago. Okay, so I'm just saying, before we go rushing into this, we might want to think about making sure that it really, all of it will fit here. It's kind of like in the olden days, if you had an allergy to fish and to caviar, did you go under allergy to fish or allergy to eggs? Who knows? But anyhow, so you just kind of, I want to make sure we're doing it right. Okay.
So there's 3 issues: non-nicotine use, the speed, and the episode of care. So let's do them in that order. The electronic delivery system accounts for all of the non-nicotine potential use that you described, and the beauty of it is one can use multiple codes, particularly because people will use different substances in addition to tobacco. This is use of the delivery system irrespective of what is being put into the system. Second, to the speed of the speed and pace at which we're going, we've had discussions for more than a year with many of our sister societies, as well as people here in the room, and we spent a lot of time talking about exactly the issue that you brought up. And should we be accounting for fruit flavorings, and should we be accounting for the aromas, and should we have a different code? And we recognize that, just having a code for all of that is a huge step forward because of the first point you brought up. And I would advocate that any and every episode of care, whether it's a hospital admission or an initial office visit with a child or an adult who's smoking, vaping, or using one of these devices, is an opportunity for an intervention. And in fact, there are specific CPT codes for those interventions for tobacco use, and one could argue they should be morphed into interventions for non-nicotine as well.
It says tobacco use, okay? So that's why I'm suggesting that if we're going to start including things that may not necessarily be tobacco, that we consider adding to that to make it more inclusive. Well, I don't know. And the thing is, yeah, I see those 16-year-olds smoking cigarettes, and it does put them at a higher risk, okay? But they don't have erectile dysfunction, they don't have cancer, they're not addicted, they're not even habituated at that time. Who knows why they're doing it, okay? And so that's why we have the Z codes, okay? Mm-hmm. So if it, I understand that we want something, and I want something because my population uses this too, and we want to put it someplace. I just want to make sure that it's done right.
But is it only at the Z code you're complaining, or the F and the T codes as well?
No, the nicotine. No, the F code for the nicotine habituation caused by this, no, that's correct. And the T code, those are correct.
So it's only the Z code.
It's only the Z code.
I'm looking at this code and I'm saying that it doesn't quite fit, but it's really close and we really need it. I'm not saying either of those. No, the F and T's, I love saying that. The F and T codes are fine.
Look at Z72.1.
We'll look at it.
Okay.
And Jean, thank you for those comments, but please remember to put it in writing. And if you have some possible, suggestions on a better placement and better titles, please send them. And since the request now is to consider this for October 1, 2017, please remember that you need to get those comments in by April 7. Just a reminder.
Nellie Leon, she's saying American Hospital Association. As Donna mentioned earlier, we have been getting questions about how to code these e-cigarettes, and the editorial advisory board for Coding Clinic has been discussing them for about 3 years now. So we got started earlier, and some of the concerns that Ms. Yoder raised have also been part of the discussion, because we've had questions about, well, what's in these e-cigarettes? It's not always tobacco, it's not always nicotine. Sometimes God knows what is in those electronic devices, depending on where you buy them, if they've come from certain countries where they might put other things that just produce smoke, is that nicotine or whatever. But I think that until we figure out all the substances, we'll still need a way to capture this information. The one question that we've had in the past was, what does in remission mean? What does withdrawal mean? And I know you're mirroring the structure of these codes, but part of the discussion was that these e-cigarettes were meant to help people move away from tobacco use. And so, what would withdrawal or intermission mean? And then one last point in maybe addressing some of the concerns about the Z codes, that for Z72.02, that you have inclusion terms that are mirroring what's under the F1723, so that it's very clear that it's e-cigarettes, electronic cigarettes. So even if you don't know if there's nicotine in these delivery systems, that just because it's an e-cigarette, that they would be in that same family. And lastly, has there been any consideration for also creating a similar code in the pregnancy section? Because tobacco use during pregnancy still sends you to 099.33, and it doesn't make a distinction between regular tobacco use and these electronic nicotine delivery system use. I know, it's a lot of stuff.
Well, I'll field the coding specific suggestions to Ms. Pickett and Dr. Berglund, but I will make a comment about the use of electronic cigarettes as a method or mechanism for assisting tobacco cessation or being used as an alternative. And I'll just say that it's controversial. There's definitely evidence that in adults, particularly in Great Britain, that electronic cigarettes have in fact helped individuals achieve complete tobacco abstinence and minimize the amount of nicotine that they use. In the United States and in other countries, there is some supporting data as well, but there's also data suggesting that it's not any more effective than other forms of nicotine replacement. So it's debatable. There's data on both sides, whereas I think it's really a mountain of evidence, particularly in the children and teenagers, that the use of these electronic devices is harmful, particularly in those who have never been exposed or experimented with the more standard forms of tobacco and nicotine.
Hi. From coding's perspective, that expansion is very confusing. Z7201, tobacco use, and then you have Z7209, tobacco use unspecified. As a coder, we always see in documentation tobacco use. So we can pick both, depending on what we like. And secondly is that I propose this Z72 should move to the F category, because we do have used alcohol, we do have used drugs. Why not just classify them under use in that F, what was that, mental disorder chapter?
Well,
Yeah.
to that point, the Z72 was originally intended to capture risk information or information where the person is not dependent. You would only put them in the F chapter if they had mental and behavioral disorders that were due to the tobacco use.
Well, we do have alcohol use with uncomplicated. We do have all those categories in that mental disorder. So I would put it in there and not worry about the Z code for lifestyle. So when we flip the book, I'm coming from a coding perspective,
Yes.
but I see what I'm thinking. So that's better just move to the substance abuse category.
Okay, thank you.
I'm Linda Holtzman, and I basically agree with everything everybody has said. I'm usually not so agreeable, so I wanted to, draw attention to that. Nobody is questioning the need to have specific codes for these electronic nicotine delivery systems. Nobody's questioning that. I think what's being questioned is the speed of putting it in, and tell me if I'm wrong, Jean, but I believe what Jean is saying is that we just want to be sure that we've checked, dotted all the I's and crossed all the T's before we put anything in. Because certainly it happens that we put new codes in and then over the course of the following year discover, oh, there's this little issue, that little issue. We want to try to avoid that. So your request to get all this stuff in writing is a good one. Let's make sure that we have everything thought through completely. And then Jean's whole point about the Z72.0, and it's Tina, right? Notwithstanding Tina's comment about getting rid of it entirely, but if we do keep Z72.0, it should not be called tobacco use. It should be called nicotine use. And in that case, we would have a Z72.01 for tobacco use, Z72.02 for electronic nicotine, and then Z72.09 for other nicotine use, which would, be whatever other sources are, unspecified or something like that. And that would take care of the confusion between 01 and 09, and also make clear that it's not just tobacco, it's nicotine. And Jean's point was what did you refer to it as? The F code and the T code?
F and T codes.
The F and T codes, they say nicotine, they don't say tobacco. So let's change the Z code to say nicotine. And then it's all consistent. And then I also agree with Nellie's comment, we need to do the same thing for the O codes in pregnancy.
Thank you.
Jean Yoder. The F codes are when there is a habituation or an impact where the person, it impacts their life. I may be dyslexic, but I don't get the code for dyslexia because it didn't really obviously impact my life. I mean, you guys all noticed it, but most people didn't notice, okay? So I'll never get that code even though I do have dyslexia, okay? So yes, please keep it back here. And for the electronic inhaled substance delivery system use, if we're going to make this nicotine, yeah, nicotine, cannabis, and other weird substances. I don't know. But for my population, we would love to have the code so that we can collect data on those people where it is impacting their care. Okay, so I'm not saying to delay it. I'm just saying make sure we do it. Yeah, I'm saying do it right. But okay, so
Okay.
Whatever.
Okay. Could the moderator open the line? I realize that we've not been able to have others comment other than in the audience thus far.
All lines have been unmuted.
This is Dr. James Kennedy. I believe that the weakness of the ICD-10 system for nicotine, it does not emulate the classification in DSM-5 like it does for alcohol, cannabis, the other drugs of abuse. One of the challenges, if you look at page 571 of DSM-5, which outlines the nosology of tobacco use disorder used by psychiatrists, is that it classifies the mild tobacco use disorder as the Z code of the Z code for tobacco use. So if the Z code is meant to only be a risk of a disease and not a disease itself, my belief is that we do need to expand the nicotine abuse dependence codes, whatever you may want to use in ICD-10, to correlate with the nicotine or tobacco use disorders that are on page 571 of DSM-5. And however that delivery is accomplished by electronic means, smokeless tobacco, cigars, whatever, is up to you. Thank you.
Thank you. Are there any other questions on the phone line?
This is Sue Bowman from AHIMA, and I agree with many of the comments that have been made previously. And I also think, now that I've been listening to this discussion, it seems very confusing and potentially problematic to classify the use of these electronic nicotine delivery systems for recreational use versus the types of things we were getting as questions at the coding clinic EAB that specifically had to do with medical use and helping people quit smoking, where the nicotine level would be reduced until eventually there is no nicotine in them at all. And I'm not sure how that use fits into these F17 codes for in remission and withdrawal, and how that would even be applied or understood.
Thank you, Sue. Other comments on the line? We do have others on the floor here that would also like to provide additional input. Okay. Dr. Linzer?
You know, I have no problem with the disconnect between ICD and DSM, since the DSM is not necessarily 100% accepted in that end of the community. I think that the proposals at the F&T codes certainly, certainly follow the particular pattern that exists. It just uniquely identifies this type of system. I think that especially in the T codes, where we have children getting the pods that go into the e-cigarettes and biting into them and having problems secondary to that, is a very important issue that we be able to track that very clearly, that as opposed to eating a cigarette, which is a sort of a different issue. I think what I'm hearing is the Z code seems to be the biggest issue, and you may want to go ahead and move the F and the T codes forward for this edition and review the Z code for the next edition.
Thank you, Dr. Linzer. Okay, with that, again, since it was asked that...
Sorry, I was wanting to comment on one of the questions earlier.
Sure.
One of the things that Gene Yoder had commented on earlier, I think, was, and others may have also, that with the tobacco use, that we might need to broaden that to be nicotine use. And that is something I certainly welcome more comment on. I wanted to just kind of weigh in and comment that one thing I have at least heard, I haven't gone through and directly reviewed this, but I believe that most tobacco in systems such as these electronic nicotine delivery systems are from, most of the nicotine is usually from tobacco. And if it wasn't coming from tobacco, then there probably would be a need for FDA review and approval. But if it is coming from tobacco, then there may not be such a need. And that would depend on just how things were derived. So I think that most of the nicotine that we have in this country is derived from tobacco, both because it's easier to extract the nicotine from the tobacco than to produce it in some other way, and also because if it were being produced artificially in some other way, then a case could be made that this was a synthesized product that the FDA should regulate rather than just something that was from a plant that has been very widely used for many years. So the two reasons for that would seem to imply that most of the nicotine is from tobacco. Anyway.
And again, the consideration is for October 1, 2017 from ATS. So would love to have all of your comments in writing by April 7 or sooner, like as soon as you get back to your office. No, only kidding. With that, we will end the discussion on this topic, and I will now turn the podium over to Shannon McConnell-Lamptey, who will cover the next several topics. Shannon?
Good morning. If you turn to page 17, the topic is blepharitis, and this is one of 11 topics that we'll be going over this morning from the American Academy of Ophthalmology. And at this time, I would like to invite Dr. Charles Slonim to come up, and he will be providing the clinical background. Dr. Slonim?
Thanks, Shannon. I'm honored to be here. This is the first time I've been here. As far as disclosures are concerned, I have no disclosures. In fact, I have no financial interest in anything that's ever been financially successful. As far as blepharitis is concerned, it's an inflammation. I plan to be very brief with each of these diagnoses. I know there's 11 of them, and I think most of these are going to be straightforward. Either there are previous ICD-9 codes which are no longer in ICD-10 for us. The good thing about ophthalmology is that we have 4 eyelids, so we have a lot of work to do, but the bad thing with coding is we have 4 eyelids, and frequently bilaterality and eyelids don't always go hand in hand, as we'll show you. But I think these will be pretty straightforward. As far as blepharitis is concerned, it's an inflammation of the eyelids. And we see it, there's many different types. There's seborrheic, there's ulcerative, there's staphylococcal, there's all sorts of blepharitis. But the problem is that in ICD-10, the codes were to each individual lid. And very frequently in the eyes, it's rare that you get a blepharitis of just one eyelid on one side and not the opposing lid. So we're just looking for a bilateral code where it's the right eyelids. Otherwise, we have to code right upper lid, right lower lid, left upper lid, left lower lid. We'd rather just say the right side and the left side, which would include upper and lower lids.
Okay. So, thank you, Dr. Sloan. The proposed coding tabular modifications are at category H01, other inflammation of eyelid, subcategory H01.00, unspecified blepharitis, to add 2 new codes, one to capture the unspecified blepharitis right eye with both eyelids, and a second code H01.00B, unspecified blepharitis left eye for both eyelids, with a similar pattern at the H01.01 ulcerative blepharitis, and a similar pattern at H01.02 for squamous blepharitis. Are there any comments or questions here in the room?
The structure is a little problematic for the both eyelids. So we assume on the right side, top and bottom. Why don't you expand the mouth top and bottom, upper and lower? Because when we look at it right, okay, both eyelids, we assume both sides. That's what the coding would say. So why not expand them out upper or lower, and then both, something like that. So we can collect that for you.
Okay, so currently right now in ICD-10-CM, there is a code for each eyelid.
There is up there?
There is a code. Actually, I tried to put sample. If you look at the H01.004 and H01.005, those are currently in there, and they're broken out by each individual eyelid. So what the clinicians brought to our attention was, this is usually something that's one eye with both eyelids. So it became very cumbersome when they were trying to capture these codes, and I need one code because it's my right eye and it's both eyelids.
It's always happened ulcer. The ulcer always happened both eyelid and one eye?
Well, it could be, rarely there are instances where it could be just that one eyelid, so that's the reason we do not want to pursue deleting the existing codes.
So the ulcer will have up and a lower, right? I don't have both with me, so I just threw it over. Okay.
Yes, yes, same pattern. Thank you. Any other comments or questions? Moderator, could you please open the lines for any comments or questions?
All lines have been opened.
Hi, this is Dr. Erica Reamer. So I know that there's lumpers and splitters. Maybe I missed the, what is the utility of knowing which eyelid is involved? Like, is there something that, something that they capture for research that makes it useful to know which eyelid? Wouldn't it just be easier to have some of these ophthalmology ones just be right eye, left eye, and call it a day?
It isn't for research. It has nothing to do with research. There are currently the codes are only for each individual eyelid. Right upper eyelid, left upper eyelid, right lower eyelid, left lower eyelid. That's the way they currently are. We're trying to have, we're willing to have those because frequently there can be a single eyelid that is involved. But more frequently, when there is a blepharitis, you will get both lids on the same side. So we know that it is currently splitters right now with 4 eyelids. We're hoping to lump a few together to make it easier and keep it as a bilateral, both upper and lower lid on the same side.
I guess I would just ask the coding experts, is the reason that we do it this way because that's the way, like, the CDC and the World Health Organization and the rest of the world do it, and we just leave it that way? Because it seems like if I were an ophthalmologist and I had to pick my own codes, this would be, like, I would rather just do right eye and have done.
I think I could probably answer that in that, as I mentioned, the good thing about ophthalmology and optometry is that there are 4 eyelids, and the bad thing is that there are 4 eyelids. And in all of the diagnosis codes, and some of which you will hear coming up, when an eyelid droops, when an eyelid turns out, when it turns in, when there's lashes growing in toward the eye, it can be a single lid or it can be multiple lids, and it can be one lower lid on one side and an upper lid on the other side. That's why the specificity needs to be there for that. But when a majority of diagnoses are one-sided or another, we just needed to lump it on a few occasions.
I get it. So we're just trying to be consistent. It just sort of, because I mean, with ptosis or, ectropion, with something that you're actually doing something about it, it makes sense to me to have to be able to specify which eyelid it is. But for blepharitis, it seems like it's overkill. That's all. All right, thank you.
I agree, and that's why we'd like to keep it to the right and the left on most occasions. Yes, ma'am.
This is Linda Holtzman from Clarity Coding. I think Dr. Reamer raises a very interesting point. If blepharitis typically is both lids, why don't we just get rid of H01.004, 005, 006, and 009?
Yeah, typically.
That's what she was saying.
Yes, and that is what would be probably more favorable. We do not typically want to delete the existing codes, especially since we've been live now for at least 2 years.
Okay.
But definitely it is something to think about for consideration. Please put it in writing. But yeah, because we've been live now, it would have been different had this been, right before we went live for implementation, but a little bit now, a little late. But if we don't have to, we would prefer not to delete any of the codes that are existing.
Okay. Then my other comment is, I think it makes sense to have, both lids, have codes for both lids. So I certainly like that. But I have to say, and maybe it was because I had decaf this morning instead of regular, when I first looked at right eye, both eyelids, I got confused for a second because when I think of both eyelids, I think not. So, and then I realized because it says right eye, oh, you mean, but maybe it would be clearer to say unspecified blepharitis, right eye, comma, both upper and lower eyelids.
Okay.
Because that would make it clear it's this and not this.
That's
for those other people that drink decaf in the morning.
Okay, thank you.
Just a quick comment on that. The confusion may be that under blepharitis, it is not an eye problem, it's an eyelid problem. It might be easier to say right side, both eyelids, and just use the word side instead of eye.
Okay. Please send it in writing so we can take a look at your comments and go forward. Thank you all. Okay, we'll go to the next topic, which is brow ptosis. And I'm going to ask Dr. Slonin to come over and give a little clinical background.
As I look in the audience here, I see a little bit of brow ptosis, but I will forego any comments and individual comments. The eyelids can droop because the muscle that holds the eyelid up droops over time, but likewise the brows can fall. So you can have an eyelid in the correct position, but an eyebrow drooping. They're two completely separate types of droopiness. And in ICD-9, we used to have a brow ptosis code, but in ICD-10, we lost it. And in a neurologic phenomenon, in a Bell's palsy, the right brow, if it's the right side, could droop, but in a Bell's palsy, the right upper lid will retract and go up. But the only codes we have is eyelid ptosis. So we want our brow ptosis back. And here, although it's H5781, I believe it should say right, left, and bilateral, because it can be unilateral or bilateral.
Okay, thank you, Dr. Slonin. And since he touched on the new code for the brow ptosis at H57.81, I won't go over each the other code, but I will make a note that he did request that we actually add laterality for the brow ptosis. And I'm going to open the floor up for comments. Ms. Yoder.
Hi, Jean Yoder. I see this, and I'm looking at it, and I'm not sure that it might not be more correct in the skin someplace around the L98.7, excessive and redundant skin and subcutaneous tissue. And because that's where all that extra skin that, yes, a lot of us have it, kind of goes. And I think this is a skin drooping, and so just something to think about.
Okay, thank you. Thank you. To comment on that, it is actually not excessive skin. You can have a brow, you can have a brow that is paralyzed from a Bell's palsy, a seventh nerve palsy, and the brow will fall, but it has nothing to do with excessive skin. So the eyebrow is the part considered by definition one of the adnexa of the eye and orbit. So it's really not excessive skin. It is the frontalis muscle that would normally hold the brow up is either paralyzed or has lost its fixation to the tissues underneath, and it will just descend, and it's not really excessive skin.
Right, and it's kind of the same thing with myasthenia gravis, where the eyelids and all of that kind of stuff. And if it stays here, I would suggest use additional code and have the Bell's palsy or something like that, so that people would understand. Because you know, you can have Bell's palsy, and this might not be part of it. And just to help the coders, so the coders understand that this is something that may not be part of the manifestation of the other condition. Okay?
Thank you. Thank you. Any other comments or questions here in the room? Moderator, could you please open the lines for any comments or questions?
All lines are now unmuted.
Are there any questions or comments on the line? Okay, hearing none, I will move on to the next topic. If you turn to page 37, the topic is euphoria, and here it was identified that there's an anatomical error in the descriptor of epiphora codes. So in H04.20, unspecified epiphora code breakout, it would be unknown if the problem is drainage or excessive lacrimation. If you look at code range H04.22, epiphora due to insufficient drainage, you'll see the code breakout, and lacrimal gland is at the end of each one of the codes. The gland is not involved, whereas the drainage is, and so deleting those terms, lacrimal gland, is being proposed. So this would really be just correcting an anatomical error, and I'd like to open the floor up for any comments or questions. Moderator, could you open the lines up for any comments or questions?
This is Dr. Reamer. I would just maybe say right side, left side.
Okay, thank you. Any further comments or questions on the line? Okay, hearing none, I will move on to page 38. The topic is eyelid cancer, and Dr. Slonim will come and give a little clinical background.
This will be an all-inclusive phenomenon with a number of the different eyelid cancers, the most common: squamous cell carcinoma, basal cell carcinoma, sebaceous cell carcinoma, Merkel cell carcinoma. Again, as I mentioned before, the good thing is that we have 4 eyelids. The bad thing is that we have 4 eyelids. But in reconstruction and in, excuse me, in diagnosis of an eyelid tumor, it's really specific to the eyelid, not to the side. So we're looking for specificity of each eyelid when it comes to eyelid tumors, both benign and malignant tumors, both benign neoplasms and malignant neoplasms. It's all inclusive in this.
Thank you. So we'll walk through the proposed coding tabular modifications. At category C, 43, malignant melanoma of skin, subcategory C43.1, malignant melanoma of eyelid, including canthus, to create a new subcategory, C43.11, malignant melanoma of right eyelid, including canthus, with 2 new codes for right upper eyelid and right lower eyelid. Adding a new subcategory, C43.12, malignant melanoma of left eyelid, including canthus, with 2 new codes to capture the left upper eyelid and the left lower eyelid. A similar pattern would be followed at category C4A, Merkel cell carcinoma, and at category C44, other and unspecified malignant neoplasm of skin, to create a new subcategory, C44.102, for unspecified malignant neoplasm of skin of right eyelid, including canthus, with 2 new codes for the right upper eyelid and 1 for the right lower eyelid. Also, a new subcategory, C44.109, unspecified malignant neoplasm of skin of left eyelid, including canthus, with 2 new codes, 1 for the left upper eyelid and 1 for the left lower eyelid. With a similar code breakout at C44.11, basal cell carcinoma of skin of eyelid, including canthus. Also at C44.12, squamous cell carcinoma of skin of eyelid, including canthus. At C44.13, sebaceous cell carcinoma of skin of eyelid, including canthus. And at C44.19, other specified malignant neoplasm of skin of eyelid, including canthus. At category D03, melanoma in situ, and a similar eyelid specificity pattern at category D04, carcinoma in situ of skin. Also at category D22, melancystic neva, and at category D23, other benign neoplasm of skin. Are there any comments or questions here in the room? Moderator, could you please open the lines up for any comments or questions?
All lines have been unmuted.
Are there any comments or questions on the line? Okay, thank you. Hearing none, I will
Just a quick question.
Oh, yes.
Since you're correcting these, expanding them, in the same circumstances for the blepharitis where you could have a circumstance where it's both eyelids, wouldn't it be prudent to go ahead and add the code for both eyelids since you're expanding it?
Probably not, because it would be much less likely to have a lesion on the lower lid. If it starts to march around the corner, it includes the canthus, which is the corner. If it's in the upper lid, it's going to be a pretty problematic reconstruction, and therefore it's just not going to happen as often. As long as patients come in on an appropriate time period, you're going to catch it just in one lid or maybe around the corner. I think it doesn't require that.
Thank you. Okay, we'll move on to page 52. The next topic is hemifacial spasm. This disease and consequent treatment may occur on left, right, or both sides, and currently ICD-10-CM does not have a code for laterality. The American Academy of Ophthalmology is proposing the following tabular modifications at category G51, facial nerve disorders, to create 4 new codes at the new subcategory G51.3, chronic hemifacial spasm, to capture right, left, bilateral, and unspecified. Are there any comments or questions here in the room? Moderator, could you please open the lines for any comments or questions? Okay, I'm not hearing anything. I'm going to move on to the next topic on page 60. It's lack of thalamus, and I'm going to ask Dr. Sloman to come over and give a little clinical background.
Lag ophthalmos is the inability to close the eyes. And typically, although it can be one lid that just doesn't close all the way, it's very common that both lids are just not meeting and closing at bedtime or during sleep, or in thyroid disease where the eye is pushing forward and the lid simply can't close. Patients get a foreign body sensation because the eye dries out, and by virtue of that, it's a condition that has to be treated by a number of different ways. And in this case, again, it's a laterality and lid phenomenon. Typically, if the upper lid doesn't meet the lower, it's all occurring on the right side. So lag ophthalmos is a right side phenomenon. True, the right upper lid may be paralyzed and can't come down all the way, and the lower lid may be retracted and can't go up all the way, but it's usually a one-sided phenomenon, and we're looking for laterality.
Thank you. So this is similar to the proposal we looked at earlier, where we're having the request for the right eye with both eyelids, left eye with both eyelids, and the bilateral. The proposed coding modifications are to add the laterality, as just stated, at subcategory H02.20, unspecified lack of thalamus. Also, at subcategory H02.21, cicatricial lack of thalamus. And a similar pattern would also follow at H02.22 for mechanical lack of thalamus, and at H02.23 paralytic lack of thalamus. Are there any comments or questions?
Nellie Leon, she's saying, considering the comment that Linda made earlier, would you consider, instead of saying both eyelids, to say upper and lower eyelids? Because I also learned something new today.
Okay.
Well, I've learned lots of new things. But I didn't know.
Okay, thank you. Moderator, could you please open the lines for any comments or questions?
I'm not clear why we need the eyelids, period. Like, if it wasn't before saying upper eyelid, lower eyelid, and so on and so forth, why can't you just say leg ophthalmos, right eye, left eye, bilateral?
I agree with you. It is a one-sided phenomenon. It doesn't matter if the upper lid isn't coming down. It doesn't matter if the lower lid isn't going up. There is a space between the lids upon closure of the eyelids, and it will always be on one side or the other. So very good comment. I agree.
Thank you for the comment. Again, it raises the question of whether we delete existing codes, keeping in mind that currently in ICD-10 this range of codes is already broken out at each individual eyelid. So please send in your comments if you really favor that perhaps we should reconsider and delete what is currently an existing code for that range. Go ahead.
But it doesn't look like it. It doesn't look like it is. It looks like it's going from H0220 to 20A, B, and C. It doesn't look like it's unspecified lag ophthalmos, right eye, upper eyelid, right eye, lower. I can't even do it.
Are you currently looking in ICD-10 book at the moment?
What? No, I'm looking at what you have in front of me.
Okay.
So I could go look. Okay, that's fine.
Okay.
Dr. Reamer, what's shown on the slide is just the new codes. The existing codes are not shown. The existing codes in those ranges do say...
Does have them, yeah,
Yes.
I see it now. Okay.
Okay. Thank you. Okay. I'm going to move on to the next topic, which can be found on page 61. It's meibomian gland dysfunction. And I'll invite you over, Doctor.
The upper, start with the tear film. There are 3 parts to the tear film. There's water that comes from the lacrimal gland. There's mucus that comes from goblet cells on the surface of the eye and the conjunctiva. And there's oil that comes from the meibomian glands and oil glands on the surface of the eye. So Mother Nature was very smart. She put the water in the middle, the mucus against the eye so the water could sheet over the surface, and she put the oil on the front so that the water wouldn't evaporate. Very common disease is called meibomian gland dysfunction, where the meibomian glands, there's about 40 of them, 35 to 40 in the upper lid, and about 30 to 35 in the lower lid. They secrete their little pores right at the base of your lashes, and sometimes that oil becomes thickened and becomes almost like toothpaste. It's a very common phenomenon. It is not a blepharitis because there may not be any redness or any inflammation of the eyelid. This causes significant dry eye problems because if the oil can't go onto the surface of the eye, the tears evaporate too quickly, and so it's an evaporative dry eye phenomenon. And it is a diagnosis that is very commonly used, and I believe the American Optometric Association and the American Academy of Ophthalmology are very much in favor of having this diagnosis, which is so common, especially in an aging population, for the new code. And that would require also the lids, because it could be in one lid and not the other, but it could be on both sides as well.
Thank you. So the proposed coding tabular modifications are at category H02, other disorder of eyelid, and it's to create a new subcategory H02.88, meibomian gland dysfunction of eyelid, with the breakout for each eyelid as just stated by Dr. Slolan. Are there any comments or questions here in the room? Moderator, could you please open the lines for any comments or questions?
All the phone lines are now unmuted.
Are there any comments or questions on the line? Thank you. Okay. The next topic is orbital roof and wall fracture. It's on page 69.
This will be relatively easy again. The orbit has 4 walls: the roof, the floor, the medial wall, and the lateral wall. When trauma occurs, hits the eye, a fracture can occur. Typically, the most common fracture is the floor of the orbit because the sinus is below and the pressure makes the floor break out. The thinnest bone in the body is the medial wall, the lamina propria. And, excuse me, whenever I come up north to this cold weather, because I just left Tampa at 6 o'clock this morning, my voice goes. So the floor, when it blows out, it's called a floor fracture. The medial wall is the thinnest bone in the body and has some buttresses from the ethmoid sinus and prevents it from fracturing as commonly as the floor does. But then the roof can have a fracture and the lateral wall can have a fracture. Currently in ICD-10, only the floor fracture is isolated. The roof of the orbit is considered as skull base fracture, just another skull base fracture, which really doesn't help when it comes to there are specific surgical procedures and CPT codes specific for roof fracture repairs, medial wall fracture repairs, but we're looking to have each wall individualized because any one or multiple walls can fracture in traumatic injuries.
Okay, the proposed coding tabular modifications at category S02, fracture of skull and facial bone. Subcategory S02.1, fracture of base of skull. To delete excludes one note that's currently there for orbit NOS at code S02.8. To add to exclusion one note for orbit NOS at what would be a new code S02.B, and then excludes 2 note for orbital wall at what would be the new code S02.A-. To create a new subcategory S02.12, fracture of orbital roof, with the following 3 new codes to capture each side, right, left, and unspecified. To delete the inclusion term fracture of orbital roof that's currently at code S02.19, other fracture of base of skull. At code S02.3, fracture of orbital floor, to delete the existing excludes 1 note for orbit NOS at S02.8, to add excludes 1 orbit NOS, and to add an excludes 2 for orbital wall with the new proposed code S02.A-. At S02.8, fracture of other specified skull and facial bones, to delete the inclusion term that's currently there, delete fracture of orbit NOS, and to add excludes 1 orbital wall. To add new code S02.A, fracture of orbital wall, with the following 3 excludes. Note, excludes 1 for orbit NOS, excludes 2 orbital roof, and then excludes 2 for orbital floor. There is a correction, so please note that the first line that reads excludes 1 orbital NOS, that should have been omitted. That should not be listed because this is really a proposed new code, so that would not be applicable. We're proposing a new subcategory S02.A0, fracture of orbital wall unspecified, with 3 new codes to capture the laterality, with a similar pattern at new subcategory S02.A1, fracture of medial orbital wall, and a similar pattern at new subcategory S02.A2, fracture of lateral orbital wall, and a proposed new code S02.B for fracture of orbit unspecified at an inclusion term fracture of orbit NOS. Are there any comments or questions here in the room?
In the pediatric population, for traumatic injuries, these can be a fairly significant issue. I appreciate the expansion, and I wonder, because of the clinical significance, if it would be reasonable to consider this proposal for publication in October.
Okay.
I have a technical suggestion. Can you roll that down just a little bit? Up? Yeah, up, thank you. So the new subcategory S02.A0, sorry, S02.A0, fracture of orbital wall. Actually, keep going. Okay, there we go. Okay. S02.A, fracture of orbital wall. I'd like to suggest just saying fracture of other orbital wall, because as you just explained, and I knew this, but the fact when you said it, I could actually see it in my head. The floor and the roof are also walls.
Okay.
Right? So that makes it more clear why there are excludes notes there, just to say fracture of other wall.
Okay.
Yeah.
Yeah.
Yeah, well, the roof and the floor are already elsewhere.
Yes. So if it's unspecified, it would be at the SO2.B, where it's just saying, it's just a fracture.
S02.A0 is correct, because you've got a code for roof, you've got a code for
Floor.
you've got a code for medial and lateral.
Okay.
So there's nothing left.
Okay. So that would address your question? Okay. Okay. And I have Linda's point for adding other. Any other comments or questions here in the room? Moderator, could you please open the lines for any comments or questions?
I normally agree with Linda, but I think that, to me, other would be if it wasn't lateral, medial, floor, or roof. And I'm not sure that there is another choice. So I think that this is when somebody says orbital wall fracture, but they don't specify which orbital wall, I think.
Okay. Okay, thank you. Go ahead.
I think the confusion is, as an ophthalmologist and an oculoplastic surgeon, I walk on the wall because it's a floor. Unfortunately, the roof and the floor are considered walls to us. So they're all four walls, as was brought up.
I just have a suggestion. I used to work for shock trauma. The patient got an facial trauma, completely, fractures. So I'm trying to say that there's so many codes, but we only submit 30 codes.
Okay.
So if there are multiple orbital fracture be added, because the patient do have all these facial fractures, and we can only submit so many.
Okay, so consideration for adding a multiple site code? Okay.
Multiple walls.
Wall, okay. Is that reasonable?
It's reasonable. There are specific codes for multiple walls by different names. A Lefort 1, a Lefort 2, a Lefort 3 fractures involve whether it's the fracture goes through medial wall and lateral wall, whether it goes through the floor and the medial wall. So there are other diagnosis names, but I'm happy to have a multiple when there's more than one.
I thought the 4 is for facial.
But
right?
it involves the orbits.
Yeah, and that's really confused when we try to code a shock trauma.
Okay.
We're not sure to put it, so.
I have nothing against another code. Just for the record, I'll say that my fellow and my residents are never allowed to use an unspecified code. They do, they don't graduate. They can't, if they don't know what side it is or what lid it is,
wow.
They're not supposed to do that.
But I'm working in real life, and I see a lot unspecified. So maybe 2 or more walls for multiple that be classified under that. I don't know. I'm just suggesting it, but.
And you're going to put it in writing, right? Yes.
I'm here 2 days, so I miss a lot of works.
I think from my colleagues would, if there's going to be 2 walls, I think they would prefer to list each individual wall as opposed to multiple. The whole purpose of this is to describe somewhere in data exactly which wall. As soon as you start to say multiple, you start to lose the effect of having a specificity of the wall.
Okay. Are there any other comments from the phone lines? Okay, thank you. We will move on to page 74 for the next topic. It's paralytic ectropion, and I'll let Dr. Sloan.
An ectropion is when the eyelid turns out. It can be the upper lid turning out. It can be the lower lid turning out. There are other codes that exist that aren't listed here. Typically, an involutional ptosis or an involutional ectropion is when the lid starts to lose its a tendon attachment and it just falls on its own. A cicatricial ectropion is one where the skin becomes very taut and it is actually pulling the lid out. The one code that it does not exist is the paralytic. A 7th nerve palsy in a stroke patient, in a Bell's palsy, the lid, because the 7th nerve is affected, the lid just falls because the orbicularis muscle, which tightens to close the eye, can't support it and the lid rolls out. It is a very frequent diagnosis code. It just happens to be missing. It was in ICD-9. It's just not in ICD-10. And it is an important subcategory of ectropion.
Okay. The proposed coding tabular modifications are at category H02 for other disorders of eyelid to create a new subcategory H02.15 paralytic ectropion of eyelid with the following new codes for right upper eyelid, right lower eyelid, and right eye unspecified, left upper eyelid, left upper and lower eyelid, and then for the unspecified. Are there any comments or questions here in the room? Moderator, could you please open the lines for any comments or questions?
All lines have been unmuted.
Are there any comments or questions on the line? Okay, thank you. I think we're going to move on to page 77 before a question comes over the line real quick. Okay, so the next topic is rosacea.
I hope that wasn't a commentary to my comments.
The topic is rosacea conjunctivitis, and the American Academy of Ophthalmology is proposing the following new codes to better track and identify patients with this dermatological and ophthalmologic condition. The proposed coding tabular modifications are at category H10, conjunctivitis, to create a new subcategory, H10.82 for rosacea conjunctivitis, with an instructional note to read, code first, underlying rosacea dermatitis. And please note that this is a topic that needs a correction. For the codes that are listed here, they should read H10.821 for rosacea conjunctivitis right eye, H10.822 for rosacea conjunctivitis left eye, H10.823 for rosacea conjunctivitis bilateral, and the last code should read H10.829 for the unspecified eye. Are there any comments or questions here in the room? Moderator, we're going to try it again. Can you please open the lines for any comments or questions? Okay. We're going to move on, and I think this is the last topic for AAO for today. It's thyroid eye disease, and it's on page 96.
Thanks, Shannon. I have no intention of giving you a primer on thyroid eye disease. We used to have a ICD-10 code for thyroid eye disease. Right now, in order to code ICD-9, we have to look in the E codes as well as an H code. We have to go to the E code, which is thyroid toxicosis, and then the H code, which is exophthalmos being the protrusion of the eye. We used to have 376.21. We're just looking to have a single diagnosis for thyroid eye disease that is inclusive in what we find in thyroid eye disease: lid retraction, protrusion of the eye, dryness of the surface, irritation, and it should be a single diagnosis code. Very common diagnosis code. Doesn't need to have two separate codes a mile apart.
Okay, the proposed coding tabular modifications are at category H05, disorders of the orbit, to create a new subcategory, H05.27, exophthalmos associated with thyroid disease, with an instructional note to read, code first, underlying thyroid disorder, and to add 4 new codes, H05.271 for exophthalmos associated with thyroid disease right eye, .272 for left eye, .273 for bilateral, and code H05.279 for unspecified. Are there any comments or questions here in the room?
Nellie Leon, she's saying, did I hear you right that ophthalmologists would prefer to have a single code and not have 2 codes because this code structure would require that the E code for the thyroid disorder would be assigned first? So Just trying to clarify because I'm sort of hearing two different proposals.
I think it's redundant. I was under the impression that the coders were looking for the thyroid code to be there. Thyroid eye disease, as you may or may not know, can be hyperthyroid eye disease, hypothyroid eye disease, and euthyroid eye disease. So even though the blood levels of the thyroid hormones may be normal, high, or low, the immune system can actually act on the extraocular muscles, swelling and pushing the eye forward. From our standpoint, a single code of thyroid eye disease would be all that we would need that would describe that. If a thyroid systemic code was needed, I was under the impression that was coming from elsewhere. We would be happy with just the single thyroid eye disease code.
Okay, because also the structure as shown on the screen would actually have a sequencing instruction, which would mean that regardless of whether the patient is being treated for the thyroid disease or is being seen by the ophthalmologist for the eye problem, the thyroid disorder would be listed first. And that's probably not what you want.
Probably not.
Okay, thank you.
Thank you.
Thank you. And so based off of the proposal as we originally received it, it was to restore what was in ICD-10 CM, which indeed had the instructional note for us to pick up the thyroid disorder first. So we will take this back to AAO and look at it again and just make sure that we're capturing what is going to be useful for them and that we are still staying within the structures of what are currently in place for ICD-10 CM. Okay. Are there any other comments or questions here in the room? Moderator, would you please open the lines for any comments or questions?
All lines are unmuted.
This is Dr. Reamer. I think that you probably do want theoretically the code also underlying thyroid disorder, because as Dr. Said, it could be from hyperthyroidism, it could be from hypothyroidism, it could be somebody who's euthyroid. So if it's from thyroid disorder, you'd probably want to specify what it is. But I guess you have to keep in mind that these codes are not really only for the ophthalmologist, but it could be that the endocrinologist is going to be wanting to specify that the patient has exophthalmos and he is referring to the ophthalmologist, so that it's not only for the ophthalmologists to use these codes, but they might want to use these, and then it's important to have the underlying thyroid disorder instruction for the coding.
Thank you, Dr. Reamer. I'm glad you were listening to what I said and that I wasn't listening to what I said. Yes, I think that's a very important point, and I don't think we have to take it back to the AAO. I think having that the systemic underlying thyroid disease there as a first code, I think that's very important.
Although I'm not saying necessarily it should be the first code, because I think the ophthalmologist might want to use the exophthalmos as their first diagnosis, and the additional diagnosis of the thyroid disorder would add detail to that, whereas the endocrinologist who's seeing the patient for the hyperthyroidism might want to use that as their first code, and the exophthalmos, which is the reason for medical necessity why they are sending them to the ophthalmologist, as a secondary diagnosis. So I'm not sure I would keep it as code first. I might make it code additionally.
Or like a code also note? Would that? Okay.
I think. I will defer to you real coders. I just pretend I'm one.
And they're actually in the room nodding, Dr. Reamer. So yes, I think that looking at it as a code also note looks to be something that's favorable here in the room.
This is Linda Holtzman. Dr. Reamer doesn't always agree with me, apparently, but I do agree with her in this case. And speaking from a coding perspective, I'd say use a code also note, and that takes care of the problem.
Okay.
And the sequencing is at the discretion of the circumstances of the encounter. And she's absolutely right. The ophthalmologist may wish to use the eye code, and the endocrinologist may wish to use the thyroid code, and they're both looking at the same condition. So.
Right. Thank you.
This is This is Sue Bowman. Well, I would prefer to go that route. I'm sure I don't have to recommend this to CDC, but I recommend that you look at other similar situations. I think we need to be careful about being consistent and within the structural organization of the system, and not just sort of do willy-nilly with individual circumstances because if we want to. I think we do need to make sure that we are being consistent and look at other similar situations and how best to handle this.
Yes, thank you. Thank you. Thank you, Ms. Bowman.
Dr. Jim Kennedy, I just want to make certain that we not use the designation of use additional code, because as we ran into the COPD with pneumonia, sequencing issues, as Dr. Reamer said, the reason for the encounter is maybe the eye disease itself, not the thyroid disease. So I'd like the code also designation, not the use additional code designation. Thank you.
Thank you. Any other comments or questions on the line? Okay, hearing none, I'm going to turn the podium back over to Dr. Berglund.
Thank you all for bearing with me for the last 39 minutes. I do appreciate it very much. On behalf of the American Academy of Ophthalmology, thank you all very much.
Okay. Thank you. And let me call Dr. Paul Rao up. I told him we would get him on this morning, and it's 11:59 still. So, Dr. Rao, we're going to talk about non-ruptured cerebral aneurysm, page 66 in your handouts. Dr. Rao is the past president of ASLHA, the American Speech, Language, and Hearing Association. He is an expert on stroke rehabilitation and aphasia, and he's on the editorial board on topics in stroke rehab. I will pass it over to you, Dr. Rao.
Thank you. And how do I forward this? Just green?
Use that to forward. And could we have the slides on non-ruptured cerebral aneurysm? We have got your slides too, and let's see.
Okay.
There we go.
So first off, I have no disclosure page because I have very little to disclose. I think one of the big reasons is I live 3 minutes from here. I am a speech-language pathologist. I'm not a physician. I was referred by the Reed Smith firm to talk about coding in this area, so stroke is a big interest of mine, so I hope this is beneficial. So, the intracranial aneurysm, we want to talk about the causes, symptoms, and the treatment. And the ICD-10, the bottom line is does not have sufficient granularity, and I hope to be able to explain that. Common characteristics we're talking about are size, saccular, non-saccular, in type, and size, small, large, and giant. So the new codes will help us help facilitate improved outcomes, research, and treatment, and being with the compliance guidelines. So what is an aneurysm? It basically defines for you weakness in the side of the artery, like an inner tube, and the blood flow within the artery weakens the thin portion of the wall, and an aneurysm occurs. As the artery wall becomes weak, obviously it swells and balloons. The pressure may eventually cause the aneurysm to rupture, so we want to get there before the rupture. And I apologize for the voice. My granddaughter had a basketball game Friday night for the quarterfinals, and I was inappropriate. The aneurysm prevalence data is about 6 million people, 1 in 50, more common in women, 3-to-2 ratio. And the age range that it's most prominent in, 35 to 60, most adults over 40, though, is the highest incidence. Did I go to? No. All right. So the signs and symptoms, again, if you think about this, the unruptured brain, very similar to what might be stroke symptomatology, where you would call 911. Severe headaches, blurred or double vision, muscle weakness, speech, slurring speech. So these are all kinds of indicators of a medical emergency, and so obviously you need medical treatment. So the diagnosis is done by an MRI or a CAT. It might be angiography, where you inject dye into the blood vessels to see where the aneurysm is. The considerations are you want to see the type, size, and location. Those are the three major questions, and whether there's a risk for rupture in the individual's age, their health, and their personal and family history, and then risk thereof of treatment. So, real simply, there's two kinds. You've got the saccular aneurysm and kind of the circumference non-saccular aneurysm. And so with the saccular, it's got this little stem, it's kind of a ballooning, and the blood flow is common in and out. And this most commonly occurs in adults. The non-saccular aneurysm is formed by this widening of the wall. There is a difference in blood flow out longitudinally separate. It's commonly called fusiform. I'm not going to try and pronounce these others, so let's call it fusiform. And then it's this spindle-shaped, it almost does look like a balloon. So, saccular versus non-saccular aneurysms, the different clinical practice that we're looking at. The clinical literature routinely differentiates between the two. The Brain Injury Foundation saccular aneurysms are most common cause of non-traumatic subarachnoid hemorrhage, and the fusiform, or the non-saccular aneurysm, seldom ruptures. It's that kind of ballooning of the artery where there's a circumference. The treatment options vary. For example, the endovascular coiling, stenting, surgical clipping for saccular aneurysms, and flow diverters for the giant non-saccular fusiform aneurysms. Classification by size, NINDS classifies them as 11 millimeter or less as small, larger are 11 to 25, and then giant or 25 or greater. Some organizations and researchers use slightly different sizes. It would be really helpful then to have this standardized, not by different organizations, but have one uniform size metric. So in Lancet 2003, the University of Texas talked about health science. Bottom line on this slide talks about the 5-year aneurysm rupture risk, size and location. So went from anterior to posterior. Clearly the larger aneurysms that are in the posterior, higher risk of rupture. Aneurysm size, treatment and outcomes. So the giant aneurysms pose particularly significant risk. Treatment for non-ruptured aneurysms may vary. For small, that's less than 11 millimeters. Medical management. For surgery, clipping, endovascular techniques such as stent-assisted coiling, deployment of flow diversion stents for larger and giant aneurysms. And again, type, size, and location of aneurysms can be consistently linked to surgical risk and outcomes as per the AHA, American Heart Association, and the American Stroke Association. The current ICD-10 diagnostic, as I said, lacks granularity. It's 167, other cerebral vascular disease. And so there's only one code, and we're no way to capture the differences. So we need more specificity, especially in terms of size, to look at the size of the aneurysm. There's no way to document compliance with guidelines, such as the AHA and the National Stroke Association. So it would be very helpful if there was a uniform coding standard. So the request is a new ICD-9 code, which we are differentiating between non-ruptured saccular and non-saccular fusiform. The further differentiation is by size, 11 millimeters or less, 11 to 25, and 25 or greater, the giant. So this is the bottom line. We're looking for the new code 167.10, which is a berry or the saccular aneurysm, and then the 167.11, which includes the fusiform. And then you can see specifically each code is looking at the small, the large, and the giant. So those are the code requests we have for the ICD-9 diagnosis code request. And I think That's it.
Okay. Any clinical questions for Dr. Rayo?
The sacral or non-sacral, does it occur in the carotid artery?
It occurs in the brain, most often some of them are more basilar or the posterior section, less frequently in the frontal.
Well, no, I'm looking at the code itself, the I-7.10, is include internal carotid artery aneurysm, right?
I would defer that to medical expertise.
So I just want to know, whatever the sacral or non-sacral occur in that area, because if aneurysm occur in the carotid artery, right? What code are we using? If it's internal. So I'm looking at your code proposing for sacral or non-sacral. I just want to know if it's classified in that area, where would we go? To go to cerebral too? Because you didn't, because then that's the case, then the I-67.110 should include that artery for us.
Well, the internal carotid artery does have an intracranial portion, and that I believe that one can potentially have saccular or non-saccular aneurysms also, although I think most of these tend to be more peripheral, not part of the internal carotid. But we do have that as an inclusion term, and so it would be reasonable if there was a saccular aneurysm of the internal carotid to be more specific as to where that was, if it is specified in the record, certainly.
Right. So if you can ask the inclusion note under I-67.11 to say to also include the internal carotid artery.
We could include that also,
right.
certainly.
Thank you.
Yeah.
Jeff Linzer, American Academy of Pediatrics. The values that you get for the size differential, where did those come from again?
There's different organizations give different data. The one was from the Lancet 2003 article, Health Sciences. There are other organizations. I have another slide which we deleted, was very, very busy, that had the specifications. I don't have it with me. Gail does it. I can answer it afterwards. I'll pull that slide.
So there's no standardization then for the size. So I would be hesitant to add the size in the code titles because what may be a small for an adult may be a large for an infant or a young child. And unlike, for example, body mass index that the CDC publishes and is standardized, since there's no standardization for size, I would probably remove that from the code titles if the proposal moves forward.
I would ask Gail Dobert to respond.
Hi, yes, my name is Gail Dobert, and I'm a healthcare attorney, and in putting this together, we worked with CMS, and we pulled together a variety of experts in aneurysm care, and we worked with, Dr. Rye was here yesterday presenting on the procedure codes for the mechanical thrombectomy and aneurysms. There is uniform agreement that giant are above 25. The large, most of the recommendations from various different groups that have tried to characterize these go from 7 to 10 up to 25. And then below that, some of them are considered microscopic and there's no treatment, and those would be picked up, let's say, if an adult had a fall and they did a CT scan and they found something that, and the consensus was we didn't need to get to that level of granularity for microscopic that were not being seen for the purposes of treatment for aneurysms. And aneurysms may occur in children. I actually don't know the incidence for that, but the vast majority occur in adult life and later in life as you approach 50. And so that's how the sizing characteristics were done and vetted with the doctors treating this.
But unfortunately, the code set applies across the age range, and 25 may be considered the standard for an adult, but not necessarily in the pediatric population. And aneurysms do occur in children. So I don't think that you can add that type of specificity for size if this is supposed to go across all age groups.
Nellie Leon, Chief St. American Hospital Association, and I agree with Dr. Linzer. Whenever we try to put something in the classification, then people, in terms of measurements and things like that, people take it as gospel. And then if there's a difference of interpretation or different age in the patients, then that creates problems and people don't know what to do with these codes, whether it's in this grouping of codes or any other. So I would suggest that we can leave the language about small, large, and giant and let the individual physician then determine, how do they categorize them, but let's not put in the actual diameters for these aneurysms.
Linda Holtzman, Clarity Coding. Once again, I agree with everyone. I think there is value in differentiating these types of non-ruptured aneurysms, saccular, fusiform. And I also think there's value in differentiating by size, because I know the treatments are different depending on those factors. I swear this came up before. I mean, I'm old and I've been coming to these meetings since like 1985, but sometime between 1985 and today, this same topic came up. I'm gonna have to go back, and it might have been 15 years ago or something like that. But I swear this came up before, and part of the issue had to do with including metrics. The ICD-10 and ICD-9 before it should reflect the clinical consensus. It should not set the consensus. So trying to standardize via the code system, I think, is backwards. But again, I like the notion of differentiating small, giant, that kind of thing. So maybe, I think Nellie is right here as well. Maybe we can leave those terms in, and you, physician, whichever society you belong to or profess or follow or whatever it is, you can, go with that, as opposed to providing something for coders to, in some ways, interpret. That doesn't
Yeah,
seem
I
right
think
to me.
the key takeaway for me reviewing this literature was to be able to get to outcomes and risk factors and get some data where you can differentiate other than just 167. So small, large, and giant is important, and I think also fusiform and saccular.
Donna, I think this might have come up before, not as a diagnosis issue, but as a procedure issue.
I'm not sure. Well, I will stop and hold. I'm going to actually ask that we go over to the codes. I had not at this point actually presented the codes, so but we've been talking about them quite a bit, I recognize. So I want to actually quickly go through those and so that everyone's aware of them. Could we have the display shifted, please? Thank you. Good. So we've got tabular modifications. I'm going to go through these very quickly. And Dr. Rao, please don't leave because we may have more clinical questions too. But thank you. So let's quickly look through these and look at what we're proposing. At I-67, other cerebrovascular diseases, we have I-67.1, which is titled cerebral aneurysm non-ruptured. We've got a number of inclusion terms here, including things related to internal carotid artery aneurysm, as was noted. And we're proposing a new code. This is a little different than what we saw earlier there. It's I-67.10 would just be cerebral aneurysm non-ruptured unspecified. So we wouldn't know the type or size, and when we just have that, then we would use this code I-67.10. Cerebral aneurysm NOS would go there, and just internal carotid artery aneurysm NOS would also go there as inclusion terms. Next, looking down, we also have a new subcategory proposed, I-67.11. This would be cerebral aneurysm non-ruptured saccular. Berry aneurysm NOS would also go to this subcategory, and presumably, presuming that we know the size, we would use a more specific code. And we would have new codes here, I-67.110, cerebral aneurysm, non-ruptured saccular, small. In this proposal, we do also have that saccular non-ruptured cerebral aneurysm less than 11 millimeters is proposed to be an inclusion term. Now, we've already heard that some people at least didn't think we should actually specify the actual size. There might be concern that maybe coders would be then trying to make a diagnosis off a radiology report or something, and we don't want that happening either, so that's something we are certainly happy to hear comments about. So also proposing a new code, I-67.111, cerebral aneurysm, non-ruptured saccular, large. As we'd said, there may not be complete agreement on what would constitute large. It would be roughly 11 to less than 25, or up to about 25. Then we would also propose a new code, I-67.112, to correct the record here. It should be 112, and that would be cerebral aneurysm, non-ruptured saccular, giant, and that would be over 25, or it might be appropriate for it to be 25 and over. We may need to talk about that also. Or we may just need to leave those out and just use the terms small, large, and giant. And then we would also have an I-67.119, correcting it should be 119, cerebral aneurysm, non-ruptured saccular, unspecified size. So those are the proposed codes for saccular. And we will, let's look to the next page, actually, if you could, advance. We have other non-ruptured cerebral aneurysm. This would include fusiform, non-saccular, and also lateral non-ruptured cerebral aneurysms. Lateral being another one of the terms that one may encounter if it's just on one side, but not fusiform, as it were. That would also go here if it's not saccular. So we would be proposing 4 new codes here also, I-67.190, other non-ruptured cerebral aneurysm, small, and it would also include non-saccular, non-ruptured cerebral aneurysm, small. A new code, I-67.191 for other non-ruptured cerebral aneurysm, large, non-saccular, non-ruptured cerebral aneurysm, large would be an inclusion. And also in I-67.192, other non-ruptured cerebral aneurysm, giant, also including the term with non-saccular, similarly to the others. And then a I-67.199 for other non-ruptured cerebral aneurysm of unspecified size. And that would include non-saccular with unspecified size. So while these proposed codes do have, at this time, the sizes listed based on comments, we could remove those. As has been commented, it's not always ideal to try to define things like this based on the ICD codes. It's good if there's already clinical agreement to make sure the terms used will help you to arrive at that. There could be some issues with not specifying it, but there might be more issues with specifying the size as we're hearing, and we are very much open to hearing more about this. Yes, a comment.
As a coders, I'm asked for flexibility. We can read MRI, and MRI can say the size, so you can, how many millimeter and so on. So just take out the small, large, and giant, whatever it may be, and just give us the millimeter in that group, and we can classify appropriately. Just give us the flexibility. We hate to bring this to doctor inquiry. Please tell me small, large, or whatever, giant.
Okay, so you're telling me the opposite of what we were hearing from others.
Yes.
You would like to see the size.
No, I would like to, yeah, I would
sorry,
like to flex.
you would like to see the millimeters rather than the, okay.
Without provider can say non-rupture, what may be. We can look at MRI and see the size of the MRI and classify as such. Give us that flexibility. Then just have small, large, and so on. Because we can do that for cerebral infarction, where the actual infarction MRI, we can classify to that particular artery that was infarcted. So give us that flexibility to do it, and just send another query to provider to ask for it.
All right.
Please consider it.
Okay. Thank you for the comment.
Jean Yoder, I think it. I don't think that NCHS should put that in there unless it is a standard of the community. I find many coding books put extra little information, little notes in there, and then coders will follow these little notes. But I think if we look at the small, large, giant, the community will get used to using those. I mean, the people who see aneurysms are going to say, they're going to modify them. They're not just going to say, wow, look at that aneurysm there, okay? And so unless there's a defined, I mean, Pluto is no longer a planet, and that was a decision that was made, okay? And so until this becomes...
And Ceres isn't a planet either for even longer. Never mind.
My goodness. So I don't think we can put this in there until it's defined, you know, and in stone, and Neil deGrasse Tyson has nothing more to say about it, okay? So, oh well.
Okay, well, please put all these comments in writing. We definitely appreciate them. And could we open the phone lines for comment also?
This is Dr. James Kennedy. This is Dr. James Kennedy. We cannot, on an inpatient basis, code from the size of an aneurysm if solely based on the radiology report. We can only code the location of any identified disease that had been previously documented. So as such, to be able to take the size of the aneurysm and translate that to a code would require a change in the index, in the guidelines or explicit advice from coding clinic. Thank you.
Thank you, Dr. Kennedy. And other comments?
Hi, this is Dr. Erica Reamer again. So I was thinking about this as well. I have a concern. What if somebody calls a 10 millimeter saccular aneurysm large, and then it's going to set up a conflict? So the question to me becomes, did we pick these numbers because NINS picked it, and they picked it because there's a difference in treatment and or outcomes such that what we want to capture is less than 11 millimeters, 11 to 25 millimeters, greater than 25 millimeters, whether you call it small, large, giant, or you just say it's a cerebral aneurysm, or whether there's a distinction according to whether it's small, large, or giant, and that's how the doctors decide what their treatment is going to be. So I think we just need to sort that out and then determine which really needs to be the specification and which needs to be, a non-necessary modifier or whatever, or a description, or whether it just needs to be left out and be advice.
Okay. So we will definitely be looking at this further. And again, I will encourage everyone to put comments on this in writing, and we will be evaluating all the comments and looking at this and determining what needs to be done with it and whether we need to bring it back further if need be, but we'll see.
Dr. Berglund, this is Sue Bowman. I just wanted to add that I agree with pretty much what everyone previously has said, even the people that conflicted with each other, because I understand the issue with including the size even as an inclusion term, and I definitely recognize Dr. Linder's point about the pediatric population being different, but I also completely agree with Dr. Reamer's point that without some kind of standardization of what these codes mean, it's almost pointless to even have small, large, and giant in the code descriptor because that's now in the eye of the beholder, I guess, and so the data becomes pretty much meaningless, and what's small to one is large to another, and how do you even compare the data and even know what you're looking at? And I'm also concerned that, it may not be documented as small or large to begin with, so then the coder's either going to have to query every time, or we're just going to be defaulting to the unspecified code anyway, and a lot of these breakouts won't even be used. But I do have some concerns about describing something with these kinds of adjectives without any kind of guidance or direction on a standardized approach to what those terms mean.
Okay. And Linda.
Linda Holtzman, having agreed with everybody else before, I also agree with Sue and Dr. Reamer that you can see it all ways. So I believe that there seems to be consensus that it's worthwhile to differentiate between saccular and fusiform. But we need to do a fair amount more thinking about the sizes. So it seems like this might need to come back at some point and offer other possibilities, but give people plenty of time to think the sizing through.
Well, that's something we'll hope to have comments in writing. It seems these are clinical concepts that are certainly described, but when they're not necessarily applied uniformly, it can certainly be awkward. I can see that. So that's something we will look at and we'll take under advisement, if you like. Any other comments from the phone lines? Hearing none, we'll stop. Dr. Routh, thank you for being here, and thank you for all the thank you for the presentation and the comments. And I will turn things over to Donna here now.
Well, it is now 12:29. I think we've all worked very hard, and our brain cells likely need replenishing, so we will go ahead and take our lunch break. We'll come back at 1:30. And just so you know, it'll be a prompt 1:30 because we still have a fairly large number of proposals to go through. So enjoy your lunch while you're preparing for the afternoon.